Good morning, everyone. Good morning. Thank you all for being here. Welcome to the 15th International SADS Family Conference. After several years, we finally have it, and we're really grateful for everyone coming, except for whoever traveled and brought the cold weather. You could probably leave, but everyone else can stay. We do have a great agenda planned, and we want to say that today is all about you and all about the patients and the families, so we hope that you get what we plan for you to get out of it. And we plan for it to be very informal and interactive, so we're very happy that you're here. A couple of housekeeping items. We do want to let you know there is a yellow sheet in all of your packets, and then when we're done, we would love for you to fill it out so we can get a sense of how we're doing. And we do want to thank a bunch of people. We thank SADS for organizing this because, without them, getting a group of us together like this is a hard thing to do. And we want to thank a bunch of our sponsors who helped make this happen. It includes Biosense Webster, Boston Scientific, Cardurian, LifeSure, Pfizer, Stride Bio, and Tenaya Therapeutics. So thank you for them and for their support. I want to start by just calling Mike Ackerman up to give us a quick welcome, and then we'll get the agenda started. Thank you.
Mike, what's the staff?
Yeah. Well, good morning, Dr. Kim. Thank you. I was the first floor greeter, if you weren't sure. So for those of us who are lost like me, greeting you and escorting you to the elevator. I'm Mike Ackerman, and it's great to get to be with you. And thanks for taking the time out. And I want to thank Dr. Kim and Dr. Miyake and the Texas Children's Hospital for their support of this. And it really, yesterday with the CME course with the physicians and the allied health professionals, it was fantastic. We had a great time, but this is the time that I personally love even more, is the time to be with the families, because that's what we're all about. And so I've had the privilege of serving as the president of the board of SADS now since 2006. SADS is 30 years old since it was founded by Dr. Michael Vincent, the late Dr. Vincent. And so it's just trying to continue his legacy. The whole purpose of SADS is you. So we generally don't fund research. We direct to research, and you're going to hear about latest updates in research. But we really are the go-to place for any and every family who has one of these genetic heart conditions. So whether yours is long QT or CPVT or Brugada syndrome or ARVC, this hopefully is your home. Hopefully you felt that SADS Foundation is your home and your resource for answers. Some of you may be a sudden cardiac arrest survivor and they still haven't figured out the why. And we're still your home if it's unknown, unexplained sudden cardiac arrest. And it's not lost on us that some of you may be here because the way you discovered it was through tragedy, where there's already a family history of sudden death. And so we certainly think of those who are left behind. SADS Foundation, we have an incredible leader in Alice Laura, our CEO. So Alice, our CEO, Marcia, the Director of Education, Jan, the Director of Fundraising and Development, Anna, who is really the Director of Social Media, and Aaron, who is the Director of everything. Is that right, Aaron?
Genevieve was with the kids.
Yeah, Genevieve's downstairs with the kids. These 6 women are beautiful and incredible in their commitment and compassion to make a difference. And so hopefully this meeting and our time together will be a difference in your lives, and it'll be a marker point where you'll say, I am really, really glad that I chose to come here. Whether the come here from was New Orleans, my favorite Mrs. Nora Lambert, or New York, which we just met somebody. New York is Amy. So wherever you came, or the tip of Texas. So wherever you came from to join us, I'm just going to trust that you're going to be really, really glad you did. So let's get the program going, and I'm really excited about coming back at 11 o'clock for the fireside chat before I bolt to catch an Uber. So let's take it away, Dr. Kim. Thanks, everyone.
I know. I'm just trying to get this functionally up. Okay. So we're going to go ahead and get going. And for our first speaker, I want to welcome Andrew Landstrom, who spent a bunch of time with us here. But he's going to come up and speak to us a little bit about personalized medicine. And so, Andrew. Is it loaded on here? Yeah.
Well, thank you, Jeff. And I'll just echo some of the gratefulness that was talked about earlier. I'm very grateful for the SADS Foundation and for Mike Ackerman for kind of bringing us all together. It's a wonderful, wonderful organization. I'm very grateful for the TCH folks here, Jeff Kim, Christina Miyake, and the other folks who have hosted us. Many of you may know that this is one of the best places in the world to get cardiac care. And so for them to host us in this wonderful place is a real treat. And I'm grateful for all of you. You all took time out of your busy lives to come here. Many from, it sounds like, very far away. And so I want to thank you for being here. Thank you for taking the time. And I hope over the next few hours that you take something from this that maybe gives you a little bit more about the diseases that you all grapple with every day. Maybe nudges you into a role of maybe leadership and advocacy in this space. Because people like you are sorely needed to help others. Because you all get it. You all are here. And thank you all for being here. It's my pleasure today to talk a little bit about precision medicine in SADS disorders, from predicting those at risk to individualized therapy. And we should have time at the end for some questions and answers if it fits the agenda. I have no disclosures or conflicts of interest, although you should know that I do receive salary support from the federal government and not-for-profit organizations, as does my research lab. We're going to talk about three things today. Since I'm the first person up this morning, I'm going to share a little bit of sort of background information to kind of make sure we're talking about the same thing when we're talking about SADS as a genetic disease. We're going to talk about genetic testing and how this can be used to individualize your care. And then we'll talk about how we might be able to predict SADS conditions early in life. And this is something I'm very excited about. This is something I think is going to be happening in the next 5 to 10 years. So these are some of the SADS disorders. There are things like long QT syndrome, short QT syndrome, Brugada syndrome, CPVT, also known as catecholaminergic polymorphic ventricular tachycardia, idiopathic ventricular fibrillation, and arrhythmic cardiomyopathy. All of these, as you know, can cause missed beats of the heart, electrically destabilizing the heart, which can lead to life-threatening arrhythmias. All of these are also genetic. And what does that mean? This is how I think of genetics. A gene is sort of like a cookbook and a recipe within that cookbook to make something. The cell uses that recipe through a message called mRNA, which moves that message into the main part of the cell, which actually can make that recipe. And the recipe in this situation makes an ion channel. That's the kind of blue and green thing right here. And so if you have a good recipe, you can make a good ion channel. And that ion channel is needed to keep the heart electrically stable. With every beat of the heart has to depolarize and repolarize, electrically fire and reset. And that has to be coordinated. And if it's not, there can be instability electrically. Now, what if there was a misspelling in that recipe? I think of misspellings as kind of two different types. This type is a single word change or a single letter change in that recipe. Say 1 cup of flour for 10 cups of flour, right? That would still make a recipe, but that recipe would not be right at the end. I am not a baker, but I can imagine if you add too many cups of flour to a recipe of cookies, your cookies are not going to be very good. They still may come out, but they're not going to do their job. So just like that single spelling error changes the recipe for a batch of cookies, a single spelling error in a SADS gene leads to a protein that may be there, maybe not, doesn't quite work, okay? And that recipe means the heart is electrically unstable. You can also have a big change in the gene, something that throws off the entire recipe such that the recipe ends. You can't actually follow through with the recipe. In that situation, you may never even get those cookies. And these are the kinds of mutations that we're talking about. Single nucleotide changes, single spelling errors, or big changes, loss of function changes. And different SADS conditions have different kinds of mutations. Making sense? Okay. We can leverage what we know about these genetic causes to customize your care. I'm a pediatrician, and so I don't like sticking kids with needles, so usually we go for cheek cells. That's what these are. But cheek cells, like blood cells, have DNA in them, and we can look for that misspelling in the DNA to find the molecular diagnosis for the SADS condition. And if we can, that gives us lots of information about what went wrong in that recipe and how best to fix it. So we can take, these are cheek cells. We can extract from these cheek cells DNA, find the exact misspelling in the DNA. You all see it here? There's a double peak. Where there's one peak, where there should be one peak, there's actually two. That's the misspelling. And that single misspelling is enough to throw off this thing, which is a picture of a potassium channel. And this potassium channel, well made, just doesn't work the same. And that's enough to give you a loss of function. So this is a science experiment where you can actually say, how much does that potassium channel move ion current through it? Big waves are good, small waves are bad. And just with that spelling error, that G to an R at position 245, that single change in the recipe, the cookies are made, but they don't taste very good. And that's a loss of function of that sodium channel. And that's enough to give you long QT syndrome, that one single spelling error. Traceable back to the DNA so that we can tell you the entire mechanism of how that disease occurs, and that gives us tremendous power to individualize your care. There are lots of different SAD conditions. There's lots of different genetic conditions that can lead to our various diagnoses. These are just some. And depending on the type of mutation that you have, one can develop one kind of SADS conditions or another kind. I'll show you one example. This is SCN5A. Has anyone ever heard of SCN5A in this room? The sodium channel, maybe? Some hands, some nods. SCN5A is a gene, a recipe, that encodes the cardiac sodium channel. One kind of mutation can lead to long QT syndrome when that channel doesn't close right. A gene mutation in that same area that causes the ion channel to not be made or not work well leads to Brugada syndrome. Okay? So one example of how one gene can lead to two different diseases. But again, understanding this genetic process and understanding how these genetic changes cause changes in the heart cells is incredibly important, and we can leverage that to provide better care. So if you've been on Twitter lately, you may have seen Mike Ackerman mention that anybody with a SADS condition should get gene testing. I agree with that. And that's because the gene testing allows us, like we've been talking about, to identify that misspelling in that gene that leads to the arrhythmia syndrome. And we can do a number of different things with that. The first and most important thing, in my opinion, is to find that mutation and to see if anyone else in the family has that same mutation too. Because even if they don't show any clinical signs of disease, having that spelling error means they're still at risk. Doesn't mean they're going to develop disease in the same way, but it means they're at risk and need to be followed. Whereas somebody who doesn't have that mutation, you can take a step back and say, well, their risk of having the family's disease is effectively zero. They have the same risk as everyone else in the general population of getting diseases, but the risk from the family is zero. So that's very important. But in the past 10 to 15 years, because of some tools I'll share with you, we've really pushed forward into how that gene mutation can actually go beyond risk stratification for the family into things like precision medicine. That is, how do we treat an individual based purely on their individual characteristics, even including their DNA, and how can this mutation inform risk? And this is where there's been a lot of really cool science I'm excited to share with you. This is an example of a positive gene test. Somebody who has long QT syndrome with a mutation in the gene KCNH2. This is one of those potassium channels. And this is a pathogenic variant, something we can act on. So how do you take a gene mutation like this beyond risk stratification in the family and use it to treat a patient better? Well, have any of you heard of long QT syndrome? I presume some of you have. There are lots and lots of different kinds of long QT syndrome. There are three major kinds of long QT syndrome based on just how many people have mutations in three major genes. You're seeing the big three right here. Long QT type 1, which are due to mutations in KC and Q1, it's a potassium channel. Long QT type 2, another potassium channel called KCNH2, and long QT type 3, SCN5A. There are risk factors for having potentially life-threatening arrhythmias that are specific to each of these genes. So not all long QT patients are the same. If you're a long QT type 1 patient, your risk is a little bit higher if you're swimming. If you're a long QT type 2 patient, things that startle you, particularly loud sounds, can be a risk factor. And for long QT type 3, sleep can be a risk factor. There are also individualized therapies based, again, on the gene and your specific diagnosis. So, for example, CPVT, catecholaminergic polymorphic ventricular tachycardia, beta blockers work great, and sometimes flecainide can be helpful as well. Conversely, long QT type 1 and 2, remember those are two potassium channels, beta blockers work great. If you have long QT type 3, beta blockers can work really well too, but sometimes mixilotine could be added. Brugada syndrome, beta blockers are not very helpful, right? So understanding the genetic diagnosis and the clinical diagnosis is really important to provide customized care for you. Not all SADS conditions are the same. Have you all heard anything about gene therapy? Oh, this is going to be great then. Gene therapy is any genetic modification to a cell, like a heart cell, that produces a therapeutic effect. And this is really a phenomenal thing coming up that I think is going to really revolutionize care. It's not today or even tomorrow, it's a few years down the road, but gene therapy, just based on its name for SADS conditions, relies entirely on understanding the genes. Thus is going to be individualized, right? I'll share a couple of examples. I don't see Mike Ackerman here. This is actually Mike Ackerman's work. This was a big deal when it was published. As you know, Mike's been very interested in looking at gene therapy for long QT syndrome. This is long QT syndrome type 1. You might recall that's because of mutations in KCNQ1. Most people have mutations in one copy. Did you know your DNA has two copies? You've got two copies of every gene, aside from the sex chromosomes. Most people with long QT type 1 have a mutation in one gene, but they have a normal gene that works well too. And so their cells make two different potassium channels, one that's mutated, one that's not. What Mike has done, so I'm going to come back in the room, has figured out a way to suppress the bad mutant ion channel before it ever makes it to the membrane, and then give back a normal ion channel. That's remarkable. That's remarkable, right? And as scientists, we want to see the evidence, because you can claim all you want that you've done something. I want to see your evidence. This is remarkable evidence. So what you're seeing here are tracings of the firing and resetting of single heart cells on these lines. Your x-axis here is time. So the longer that tracing goes out, the longer that heart cell is taking to reset. Okay? So would you believe me if I told you that red line, you can't see I'll just point. That red line is taking longer to reset. Would you believe me if I told you that was a long QT cell, taking longer to reset than the normal cells? And what happens when you do suppress and replace? That time normalizes. Okay? So this is in a heart cell using single cell studies. But when you quantify it, you can shorten the individual QT of that individual cell, which is pretty remarkable. Brugada syndrome. Has anyone heard of Brugada syndrome here? Yeah. Brugada syndrome is a very challenging disease. There is really no good therapy for Brugada syndrome, right? No good medicines. We talk about beta blockers not being the best thing for Brugada syndrome. This is work that was led by a colleague of mine, Ninad Bursak, who's actually a cell electrophysiologist and a biomedical engineer, which are two very important fields that he's managed to combine in a lot of training. Brugada syndrome is caused by this, which is a sodium channel. This is what's made in our hearts that allows our heart to fire. The trouble is, if you wanted to put this sodium channel into a gene therapy, you run into a problem. Brugada syndrome, this channel doesn't work. So what you would love to do is take this channel and just simply reintroduce it into a cell. Our cargo for, or our method for doing that is a virus called AAV. AAV is too small to fit the entire sodium channel in. Nanad thought of a solution. He thought, let's think small, let's even think microbial. Bacteria are much smaller than our heart cells. So he came up with an idea. What if we could identify a small bacterial sodium channel that was like the big cardiac sodium channel that you and I all have? Up top here is a diagram of what our cardiac sodium channels look like. It's got these 4 big domains that are roughly equivalent to each other, and those all fold together to form a big cardiac sodium channel. There is a bacterial sodium channel that looks very similar to one of those monomers made by E. coli. And that fits in AAV. And so his idea was, can you take this bacterial ion channel, put it into cells, and express? We played a small role in this. We didn't do all the heavy lifting. This was Nanad. But I'll share with you one slide of data. Doing this is kind of a big deal because it's really novel. You're trying to show that you can move a bacterial ion channel into a heart cell. So the first set of experiments that we did was we tried to express this in mouse cardiac myocytes. Every cell that you see there in green is a cell that's expressing BACNAV, the bacterial ion channel. And it electrically moves sodium just like the sodium channel does in the heart. You can see that here with these big waves that show sodium flowing into the cell. And it's very, very similar to the sodium channel that we see in our hearts. And so Nanad is very interested in moving this into a gene therapy in mice. There are mice that have Brugada syndrome, believe it or not, and potentially in larger mammals and hopefully someday humans. So let's pivot a little bit and talk about how we might be able to predict SADS disorders before they ever manifest. And this whole discussion is really made possible by the precipitous fall in the cost of sequencing a human genome. So back in 2001, when the first human genomes were sequenced, they cost about $100 million. It took about 10, 15 years to do. Really expensive, right? Now, less than $1,000. And at Duke, we can sequence a whole genome in an afternoon for about $800, which is wonderful. So that changes things, right? An echocardiogram is a lot more than $800. And so the test is actually easy to do, it's cheap, and that's opened up a world of possibilities. What's the promise of this technology? Well, right now, it's sick babies in the ICU who are seeing a lot of the promise of precision medicine. You may have heard of neonatal ICUs. These are ICUs for little tiny babies. You may have had some personal experience even in these ICUs. There's a lot of babies there who are just sort of stuck. They're sick, we don't know why. The best doctors come around, they can't figure out what's wrong with the child, and this child just sort of is stuck in this ICU. Not getting better, sometimes they get worse. Whole genome sequencing in these children has revolutionized their care. So if you take these infants who are stuck, no one knows what's going on, you do whole genome sequencing on them and their parents, you will arrive at a diagnosis about 1 in 2 of these children, 50% of the time. That's a game changer. In addition, by figuring out what the diagnosis is early in life for that child, you save the family, you save that child, the healthcare system, tons and tons of time. You've heard of the diagnostic odyssey, right? Maybe some of you have been on that diagnostic odyssey where you see doctor after doctor after doctor, test after test after test, and then finally you arrive at a diagnosis. Well, in these 1 in 2 children, you can arrive at that diagnosis early, and it saves the healthcare system money to the tune of upwards of $2 million per person. So this, I think, is going to drive utilization of whole genome sequencing in the NICU, and it already has. In addition, this can be done rapidly. So this is work by Stephen Kingsmore out of Rady Children's Hospital. This is amazing. They took these children, no one knew what was going on. They rapidly sequenced the child, both parents, used artificial intelligence to pull keywords from the chart. They took humans out of it. They merged in AI the records with all the sequencing variants they found and were able to arrive at a diagnosis in less than 20 hours for these children. And that was 2018. This is amazing. This is game-changing. And I think in our lifetime, probably in the next 10 years, a whole genome is going to be our newborn screen, right? But with that promise comes a lot of challenges. I love this cartoon. So if you can't, it's a little bit blurry, but if you can't really see it, Kermit's sitting across from a doctor saying, "Have a seat, Kermit. I got something to talk to you about." And he's a puppet, right? So he was not expecting to figure out that he was a puppet. But these types of tests oftentimes have untoward consequences, and we call these incidental findings. The American College of Medical Genetics has said, okay, we know you're going to be doing whole genome sequencing. We know it's important. You may be doing it for a child who you don't have any concern for cardiac disease, but we want you to know if you find mutations in cardiac genes, they may be a SADS condition. And so you owe it to go back to the family and to the physician who ordered that test to let them know they've got this diagnosis, this genetic diagnosis. They put through a list of genes. You might recognize some of these. Most of these are actually cardiac genes. All of these on this list are cardiac genes, but most of the genes that the American College has flagged as being important are cardiac genes, and a lot of these are SADS genes. And if you look at large populations, right, these are ostensibly healthy individuals. These are huge populations where they've done genome and exome sequencing. 5% of individuals will have an incidentally identified variant in a gene that's flagged by ACMG that should be reported back to them as actionable, something that you need to know, something that your cardiologist needs to know. 1% of them are cardiac genes. So what's the problem with that? Well, unfortunately, that 1% is actually much, 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 much higher than the population of SADS people, right? And so there's a lot of signal and noise here. Some of these mutations will absolutely cause disease and should be flagged and should be returned. Many of them will never cause disease. And so we just need to get smarter about how best to pick out the sick babies who are at risk and the sick babies who are not at risk. And there's lots of work going on in this space that is very, very exciting. There are people who are advocating for genome first, right? These are individuals out at Rowdy Children's. We've talked about Stephen Kingsmore, folks at Seattle Children's, and even here at Baylor. And I think what you're going to be seeing is genome entering very early in life, and potentially SADS arrhythmia syndromes being caught day of life 1, 2, 3, if we can properly figure out which variants we have to worry about. And that is going to revolutionize care. And you can imagine if you pair that with gene therapy, you might be able to even cure the disease before it manifests. I think that's the dream. Long way to go. One thing to caution about here, this is a family of women who were told that they have a mutation in the BRCA cancer gene, the breast cancer gene. And they were told it was severe. And these women got bilateral prophylactic mastectomies because of this risk, only to find out that that mutation actually probably wasn't as disease associated as we thought. So just one counterbalancing point to highlight that while there's tremendous inertia in this field, I'm very optimistic about where we're able to go. We have to keep in mind families like you, families like them, and just be sure that we're doing this in a responsible way. And the last thing I'll leave you with is a tool that I think helps gets us there. Have you all heard of stem cells? So in my mind, there's two kinds of stem cells. There's the embryonic stem cells, and then there's induced pluripotent stem cells. The latter are what I'm showing you here. These are stem cells we can create from anybody. A sick baby in the ICU. My dad, who this year will turn 76, we can make stem cells from him. And from these stem cells, we can create any tissue we want, including cardiac myocytes. And you see them beating away here. Right? So cardiac myocytes taken from the blood of a child. This is an incredible tool that we can use to help figure out whether mutations may cause disease and to figure out more about SADS conditions that we need to know more about, like Mike mentioned, the ones where we don't know the positive gene test. So tremendous tool, a tremendous reason I think to be optimistic about what the future brings. And so in closing, genetic testing is important for all SADS conditions. The details of that gene test can confirm an individual's diagnosis, guide therapy, help identify risk factors for arrhythmias. Gene therapy is a promising target down the road for many SADS conditions and may be individualized. And we're moving towards predicting SADS conditions based on genetics, but many challenges remain. so that we know who is at risk of developing disease. And with that, thank you for your time. Happy to answer any questions you may have. Ma'am. Cord blood? Yeah.
Is that helpful at all in this?
So the question, for those who may not have heard, is can cord blood be used to make, I presume you're talking about the stem cell work?
Yes,
Anything, yeah. So cord blood, like any other tissue, will have DNA from the baby. Sometimes mom's DNA gets in there a little bit because of the birth, and so you have to really be careful. I think the major tool for cord blood is actually they grow great stem cells.
How long until the gene therapy is in human trials, and where do you sign up? How long until the gene therapy is in humans, and how do you sign up or get on the list?
Yes. Well, you're in luck because you've got Mike Ackerman here to talk about timeline for his gene therapy. I think the important thing to think about is what I've showed you today is gene therapy in cells. We need gene therapies in small mammals, right, with intact hearts to look at toxicity and efficacy. And then we need gene therapy in very carefully done trials. There have been trials even now where the individuals have had very late complications, a year or two even after the initial therapy went in. So there's tremendous promise, but we have to do it responsibly. Sir.
So I'm a similar line of gene therapy. So I'm a parent to a child with CPVT. So obviously gene therapy is very exciting for us. But to turn that around a lot, as a parent, what advice would you give when assessing risks to such a new therapy? So I think in the next 10 years, hopefully I'll have options, and we're going to have options between gene therapy. Something so new, like what risks should we be looking to avoid when we have discussions with our doctor or with our treatment plan?
Yeah. I think the key for gene therapy is that it's incredibly exciting. But there is so much that still needs to be worked out about the best way to deliver in a way that doesn't cause side effects. What gives me pause is there's some trials right now that look very, very efficacious, meaning that they do a good job of fixing the disease. These are non-cardiac diseases. The challenge, though, is sometimes people very, very late get complications, and they can be life-threatening. So I think for me, the individuals who are kind of front of the line for that are probably not children, because I think children offer a very different dynamic in this sort of quest to finding a good therapy. I also think that if you're well managed, that gene therapy may not be front of mind for you, mainly because with the therapies that they're receiving now, you know what those side effects are. Versus gene therapy down the road, we don't know what those side effects are long term. Eventually we'll get there. But I think the individuals who are probably front of line for gene therapy are the ones where it's very significant disease. You've been through all the therapies, and nothing is working.
Any other questions? I encourage you, if you feel like I'm just about to ask it, but I don't know if I want to, now's the time to do it. Otherwise we will, yes.
For long QT, 10 years ago, we were at a conference, and outside of long QT 1, 2, and 3, there was talks of other versions that are maybe not discovered or officially known yet. Has there been any updates on other versions of long QT?
There are. Mike Ackerman shared a couple of those updates yesterday. There have been some rare genes that have been discovered. I think the challenge with rare gene discovery is that the tools are so good now that if there's a rare gene that explains the remaining third or so of long QT syndrome, it probably would have been discovered a while ago. I think rare genes are going to help chip away at that, but those rare genes are going to remain rare, maybe even one or two of potentially in the entire world. The remaining, may be areas that we're not looking at in the genome. So right now, when we do a gene test, we look at what's called the exons, the areas that make that recipe that we talked about. There's lots of stuff in between those exons, lots of stuff between the recipes, the genes, that we don't normally look in. And if those have mutations that alter the recipes that we know about, that's another area. And there's also the chance that smaller variants around the genome, lots of little things compile to make a long QT phenotype. So there's a lot of work still being done.
Yeah.
I don't know if it's needed, but I have CPVT and it's more adrenaline induced. But is there other like activities or things that have been noticed where it comes out more? Or you have seen the condition?
In terms of CPVT risk factors?
I guess just for helpful to anybody, I guess.
I think in the past few years, it's been just more reaffirmation that those high adrenergic states, the lots of adrenaline states, are really what drives the arrhythmia. I think there's been great work done about medical therapies and sympathetic denervation therapies and how they can work together for patients that maybe have a lot more breakthrough than just on medical therapy alone. I think the biggest shift in the past few years has been, at least in children, kind of a move away from putting ICDs in every single last one of those children, knowing that those ICDs can have complications, and sometimes if you can manage that individual without the ICD, that risk-benefit changes. So I think in terms of just overall therapy, that's what's been happening. But in terms of like new risk factors for sudden death in CPVT, I'm not aware of like new things that have come to light in recent year or two. Mm-hmm. Thank you.
Thank you, Andrew. We will have more time for panel discussion and informal connections. So if questions do come up, we really do encourage you to engage. Next, we're going to have Bryn Deckert come up. She came all the way from Michigan, Mott Children's, and she's going to speak to us on what you can do to get the best care. Bryn.
Let's see it.
I thought I saw it loaded here. Let's see.
Maybe it's behind the
Maybe it is behind this. Yeah, we're just having trouble finding it. It's here somewhere, we promise.
Hey, Alice. Yeah. Do
you
you
know where
still see
her
the
talk was?
presentations?
You don't have your slides there?
No, unless maybe it's in here. Is it in here?
Yeah.
Oh, yeah, okay.
There it is.
Perfect.
Just inside the folder. Easy enough. All right. Okay. Thank you, Dr. Kim, for the lovely introduction. I'm very excited to be here. I'm a nurse practitioner at University of Michigan. I've been part of the SADS organization, I think, for the last 8 years, something like that, 8 or 10 years, something like that. I'm also on the board of trustees for SADS, and it's a wonderful organization. So I'm very excited to have all of you here with us today. I'm going to be talking about navigating a SADS, a diagnosis, and how to speak to your medical providers, how to find the right medical providers, and what to do when you have questions and things like that. Today, we're going to go over a few things. First, we're going to go over how to find the right care, which is very important. As you can tell with Dr. Kim, Dr. Miyake, Dr. Brule, Dr. Ackerman, who's in the room, it's very important to find a person that's an expert in what the care that you need. What to expect from your team we'll talk about, what questions to ask, and then where to find information that you can read at home if you have further questions. First, I want to start with not all cardiologists are the same. And again, going back to the presentation we just heard by Dr. Landstrom, we know that he is an expert in what he does. It is important to see an expert of a SADS condition. And as we know, Dr. Ackerman has been doing this a long time. And there's a lot of other people across the country who do this very well. But there are some people who are cardiologists and may be able to help you in your local community, but you still want the expert care from other centers. So how do you tell if your doctor is an expert in the SADS condition? You could ask, how many SADS patients do they see? Do they have a special arrhythmia clinic? Many of these big centers, like Dr. Ackerman's, has a specific center or clinic that handles patients, that evaluates patients with SADS conditions. And are they a SADS advisor? Are they on the scientific board of SADS? Can they answer the questions that you have? And really, you want to make sure that they're an expert in it. The SADS Foundation can help you find an expert. So if you don't know if you're seeing a SADS expert, you can actually contact SADS, and they can let you know that yes, this person, has produced a lot of research in this area, works with a lot of these patients. SADS also has a physician referral network, so patients can be referred from SADS to the physicians that are experts in this area. So that's tip number one, to make sure you're getting the right care. So evaluation and follow-up. Some of the things that you may wonder, what tests do I need and why? And these are the things that you can ask your provider. I'm a nurse practitioner. I see patients with the physicians I work with, and they ask me often, why are we getting this test? And sometimes patients do feel a little bit nervous about asking the physician or the doctor themselves. And there's many non-physicians like myself that you can ask these questions to. So you want to know what tests you need and why you need them. So every year we probably go into an office, or every 6 months or so, and you get a test. And usually the test is an EKG. In many instances, the EKG is very helpful with long QT syndrome and things like that. Like you were just saying with CPVT, the EKG may not be helpful. So there should be other tests that are done. That can be an exercise test, an echocardiogram, Holter monitors. There's a lot of other tests that can be done to help us figure out how you're doing and what condition you may have. Genetic testing, as we've heard and we'll hear more about, is also very important in these SADS conditions. How often do I need follow-up? Most of the time, we see patients on a yearly basis if they're stable and things are going well. If their medication compliance is good. In children, we may have to adjust their medication based on weight. So many times we can do this over the phone. So if you have a young toddler that's growing rapidly, you could call the office and say, hey, my kid gained 5 pounds or something like that, and we may need to adjust the dose. So follow-up, it can range in how often we're seeing patients. Sometimes it's yearly when things are going well, and sometimes it's more often if we need to make adjustments or follow up sooner. And you also want to know who to contact if you have concerns before your next visit. Now, in this day and age, we have patient portals and electronic medical records. So you can actually type your question many times to your provider through a portal. That portal is answered, could be answered by me, it could be answered by Dr. Ackerman, Dr. Bruhl. Those questions are easy to go through, and you can do it on your phone, on your computer. Sometimes you need to call. Sometimes it's more of a discussion. So if I have a patient who sends me a question through the portal and it's going to be a long answer, I will say, when is a good time for me to contact you? I think we need to have more of a conversation. In this day and age, also, we can have virtual care. I will just tell you that I sent a patient to Dr. Ackerman who stayed in Michigan and got the expert care from Dr. Ackerman in Minnesota. We're able to do that now with the technology that we have. And I think that is excellent, too, to know that we are all connected and we can get the information that we need to in a quick way. So you would want to know who to contact, especially at nighttime or on the weekends if something is happening and you need to reach your provider who may not be on call, but they usually have a team of people that you could contact to get your questions answered 24 hours a day. So you need to have those phone numbers and know which phone numbers to use at what time. So genetic testing and counseling, we'll go through this again throughout the rest of the day. Why I should be tested, Dr. Landstrom just answered that question, and that is for personalized medicine. We need to know the genes so we know how to treat people. We also need to know who may be affected. So sometimes with long QT or even CPVT, the tests can be normal, but the patient may have the gene. Doesn't mean we're going to implement treatment just because of the gene test. It just means that we'll follow a little bit closely and know what we're looking for. Who needs to be tested in the family? This is something that your specialist in SADS condition can answer as well. And it's usually first-degree relatives. And what steps do I take to get genetic testing? In many centers, such as my center and Dr. Ackerman's center, we have a genetic counselor. And that person is very, their job is very specialized in talking to patients about genetic testing and giving them the results. And I think that's very important to know that your center has someone that you can reach out to and that will give you the answers to the tests that you are getting. What should you discuss with your electrophysiologist? So first is treatment options. There are a lot of different treatments out there. And just like Dr. Landstrom said, it could be based on the gene that you have. What are the medications that we can use and the side effects? So can be side effects of medications. Many of these conditions we use beta blockers. Kids sometimes complain of fatigue and headache, dizziness, things like that. Usually it's not that big of a problem though. We have not had tons of side effects with the beta blockers we've used, especially when they've been on it for at least a few weeks. What exercise can you do? What sports can you play? We have guidelines out there that help us determine these answers, but we also want to work very closely with families. We want to use shared medical decision-making to have these discussions with our families. And the guidelines have changed. Many, many, many years ago, we restricted all patients who had these types of SADS conditions from doing most competitive sports. You could be a bowler, you could do curling, but you couldn't play baseball and you couldn't run track and you couldn't play hockey. Those recommendations have changed, and our new guidelines really support having people be active. And I think Dr. Kim yesterday talked about a patient that many, many years ago, he had restricted from sports, and then the patient became obese and very depressed. And we also want to keep in mind the mental health of our patients. And in most people that play sports, they love it, and that's where their livelihood comes from. So we have guidelines and we have an idea of what we should do for patients, but we also want to work with our families. So this is something that you should discuss with your provider and know what can and can't be done. Dr. Cannon yesterday was talking about there isn't a carte blanche that you can just go play any kind of football you want. We can put some parameters in play that you can play football, but we want you to stay well hydrated. You can play football, but there has to be an AED nearby. So these are the things that we can work with your families, your schools, your communities. SADS does an amazing job of reaching the communities out there for these types of things. What is the family history? Did anyone have a cardiac arrest before the patient? And these things we take into consideration when giving our recommendations. What symptoms should I be aware of? That's something that's very important. What leads to the need for immediate medical attention? And that's something you really want to work with your physician to know what that is. At the same time, we know in most of these conditions, syncope or passing out is a symptom that we take very seriously. But kids can pass out for non-arrhythmic reasons. And this is why we always stress to our patients to make sure you're drinking enough fluid, because if you pass out because of a non-arrhythmic reason, guess what? 911 is going to be called. And so if patients can be healthy, can eat right, can stay hydrated, then we can avoid some of those passing out episodes from non-arrhythmic reasons. And then what to do if you experience symptoms. I work very closely with our school nurses in the area. I talk to them all the time. They know my name, I know their name, because we work together to create plans. On the SADS website, they also have plans that a person like me can print out and give to a school. So it's very helpful to work with your school, your coaches, and things like that. Dr. Ackerman has always said to work very closely with the coach. You want the coaches to understand the disease and understand what to do so everyone is protected. Long ago in my former life, when I was in college, I worked at a camp for kids with diabetes. And I remember talking to some of the kids that they were embarrassed to share with their friends that they had diabetes. But what we would tell them is, guess what? The friend is going to be with you if you have some issue you need to be treated. So be honest and be open with your friends. At least find one other person that you're comfortable with to share this information. You don't have to broadcast it to the school, but just find someone that you're comfortable with and sharing. So how to make the most of your appointment when you see a provider. We know that providers have to move pretty quickly, but we also want to take the time to make sure that all the questions are answered. So if patients come prepared, it makes it more efficient for us. So before your appointment, choose the top 3 to 4 questions. Write them down. Write down your questions. Again, portals are very good for these questions on off times when you're not at your appointment. Take someone with you, because sometimes you're very nervous at appointments. We see this in patients, and you may not hear everything that the provider is telling you. So take someone with you who can take notes for you, who can actually also hear, and you can go home and discuss it together. And then the SADS website also has a site that teaches you how to prepare for your appointment, and all of these points are on there. So the SADS website is very helpful for all of your questions. How do you find accurate information? So first is your healthcare team. Your healthcare team is going to give you the most accurate information. Secondly, SADS Foundation has a lot of information out there. I would also ask your healthcare team what other sites are viable, what other sites can I go to educate? Because there are a lot of things out there. We all know we can Google anything and you can get 10 different answers, right? So you want to make sure that the site you're going to is based on medical and scientific facts. And so I would ask your healthcare team, can you point me in a direction where I can learn more about LongQT, CPVT, any of those things that are websites that we trust and we know, and sometimes we'll go to look up information as well. You have to remember that you're the most important person on your healthcare team. And the more you know, the better prepared you are. So really take notice and understand your disease. As your children age, you also want to make sure that they understand their disease. So we start working with children, around 8 to 10 to really have them understand what their disease is. And by the time they're adults, we want them to be able to tell us what their disease is, what the treatments are, and what the signs and symptoms of concerning things are. So this is our job to prepare your child. It's the same thing that you're doing probably at home as your child ages. When they're little, you pick up after them. You put their towels away, you fold their clothes. When they become teenagers, you say, your turn. You get to do it because you want to teach them how to live in the world. And it's the same thing from our standpoint, from a healthcare provider standpoint. So there are tons of resources for you on the SADS website. I just went through a few. The SADS website has been updated recently, and it's a lovely website with lots of information. It's very easy to follow. So that's one place you can go. There are other places that you can go. Upbeat.org is another website that is put on by the Heart Rhythm Society and has been, the information, the pediatric side was written by pediatric electrophysiology providers, myself included. So another place that you could go for more information about things. And we know that the SADS website and the Upbeat, they're not contradictory because we've worked together, PACES and SADS, very closely to make sure that we're all sharing the same truthful, scientific, factual information. Resources for you on the SADS website includes the condition-specific information, so you can look up LongQT, you can look up CPVT, you can find a physician, so I think that's very important. You can find a physician in your area if you're moving. They have support groups, which are wonderful. I've been part of these support groups, and probably many of you in this room have been part of it, where you connect with other patients who have similar conditions that you do to share your stories, because we know that the bond between patients is very real and very strong, and we want them to feel comfortable talking with other people and talking with people who have been through what they have. The Living with SADS webinars, SADS Live, Dr. Ackerman started that almost 2 years ago, and how many were over 100 and something at the moment for SADS Live, which is a wonderful program on every other Friday afternoon that you can just jump on and learn various different topics. I've been on it a few times myself. Many of our providers in the room have been on sharing with patients information. There are research opportunities, which will be discussed later on, genetic testing information, which will also be discussed later on. And so these are important things to go to and to know about for patients and learning more about their conditions. And sometimes, again, your kids can be on these support groups and join with other kids their age, which I think is very important. And I am happy to take any questions that you may have or just anything you wanted to share. Thank you. Anyone out there have challenges speaking to your provider, or everyone feels very comfortable? Anyone have tips on how to prepare for your visit? Yeah, go ahead. Sure.
Thank you. I don't currently have a primary care provider, and my condition is very new, and we're still kind of getting to the bottom of things.
Sure.
And I have other issues going on in addition to my heart problem. How do you recommend going about finding someone who can help be kind of your guide for all of the issues
Sure.
that you deal with?
Yeah.
Like a good PCP who understands,
Right. That's a great question. So it sounds to me like you're asking, how do you find your medical home? So you need a person that can help coordinate all these specialists. And what we often say in medicine was the right arm's not talking to the left arm. We want to be communicating. And I would say, so to get, to find a good PCP, I would ask for recommendations from your friends, family. I would, if you live in near an academic center, you could ask them. When you do find a PCP, make sure that your specialist communicates very closely with that PCP. So I'm often speaking to primary care doctors explaining, hey, this is the deal. We write letters, but those letters sometimes just kind of get put in the chart and maybe not read as carefully as they should be. But if I really want to tell a primary care doctor something, I will call them and say, I saw X, Y, and Z patient today, and this is what we discussed. This is important. So I did not stress that during this talk. So I do think that primary care and the communities that you are in are just as important as a specialist that you see, because you're going to be seeing them probably more often than your SADS specialist, and they're going to live in your area. So I would make sure that you find a friend or a family member who has a PCP, and actually go interview them, go talk to them and say, look, I have this, this, and this. Can you tell me how you're going to coordinate and communicate with the specialist? You don't have to take the first physician that you see, the provider you see. You can shop around. And I think that's something that's very important, to make sure that you feel comfortable with your primary care physician, and make sure that they're willing and will speak to your specialists. We're all on the same page. And that's a very important question. So thank you for bringing that up.
I know that a lot of us struggle with finding reliable resources like you talked about.
Sure.
I just wanted to offer something that my cardiologist has suggested, and I downloaded an app called Credible Meds.
Yes.
It helped me tremendously.
Yep. So Credible Meds is a wonderful website. Credible Meds is a website for patients with long QT syndrome on drugs to avoid when you have long QT syndrome that can exacerbate the condition. And the good thing about Credible Meds is it's updating all the time. So we used to print out lists and hand them to patients, and now I do not print out a list, because I don't want them to have that false sense of security that this is all inclusive. So crediblemeds.org, you have to register and you have a sign on to get in, but it's free for anyone. And you have to be your own advocate, because you could show up at a pharmacy, you could show up in an urgent care, an emergency room that doesn't know long QT, and they could give you a drug that could exacerbate your condition. So make sure you know what drugs to avoid. That's very important. So Credible Meds. Yep, they have a great app on your phone. So it's everyone always has their phone with you, right? Yeah, that's right. So and you just type the medication right in, and it will tell you what the risk is. The other people to talk to is to call your specialist. So I get emails and calls from providers, from patients. Is this drug okay for me to take? And it's always a good double check. And I do not ever mind double checking for a patient. They looked on Credible Meds, and so did I, and we came up with the same thing. So 2 heads is better than 1. So if you have any questions, then you can also contact your provider. But great point. Thank you. There are other sites out there like that. BrugadoDrugs.org is another one for patients with Brugada syndrome. And so these are important pieces of information. Those are also on the SADS website. So you can find this information, probably a link to it on the SADS website. So you don't have to go very far to look for it.
Bryn, that was a beautiful talk, and your question in that app is a great one. I just wanted to follow up a little bit on the Credible Meds, because there's sometimes some confusion about that. So it's founded by Dr. Ray Woosley, wonderful person, and I've been on the advisory board. And one of the things we've been trying to do unsuccessfully is be able to give you a feeling as to which medicines are really, really dangerous on that list, and which ones are sort of, but they got on the list anyway. And we're making a little progress on that. But the point, I think, is for you to be empowered with that list, so that's kind of, I view it as the timeout. So when any physician, healthcare provider provides you a prescription with anything, your good assessment to see if they're doing what Bryn talked about is to say, is this drug QT safe? And if they look at you like a deer in headlights, they're probably not the right member of the team.
That's right.
Because they're not respecting the issue. Now, that doesn't mean that every medicine on that list is absolutely off limits. It just means that you needed to review that with Dr. Kim, Dr. Miyake, with Bryn, with somebody, so that together we're making the decision that, yes, it's on the list, but we have enough margin. So you'll find drugs like Ritalin on the list. I have lots of long QT patients with concomitant ADHD where we are meaningfully treating their ADHD.
I will say I do like the last update with the color coding on the top.
Yeah, so it's getting better with that color coding. But I think, so what I want all of you with long QT to do, because the list is irrelevant if you have CPVT. You don't even have to know about that app. This app is only for the long QT families, is the timeout check. It's a great way for you to get a feel if they have sort of QT respect for the possibility that the drug issue is important. Because for many, many families, their only risk is somebody inadvertently stacking the deck and putting you on 1, 2, or 3 medicines on the list and then creating the perfect storm. And so for many families, that's actually the only risk. The risk is super low in many situations, but you can go from super low to really bad if you were in the hospital with pneumonia and somebody treated you with levofloxacin, for example, and nobody's thinking or respecting the QT issue.
That's right. That's right. And that's another point that Dr. Ackerman has made. Many antidepressants are also on the list. And again, in this day and age, we really are paying attention to mental health issues. So patients who need Ritalin, for example, or an antidepressant or anti-anxiety medication, we usually work out a system of how we're just going to follow a little bit more closely. But and just like Dr. Ackerman said, it's the additional medications on top of that. So when you could walk into an emergency room and get Zofran or something like that, which is on the list. So that gives you 2 of those medications and again, this is just QT, prolongs the QT interval. So it's just very important to know what they are and use your provider. So what I would say is if you got prescribed, your child or you got prescribed Ritalin or antidepressant, is I think my child really needs this. They're not doing well in school. How can we work together to make this safe for my child? And we do this often. Just like Dr. Ackerman said, we realized long ago that doing well in school sets a child up for a wonderful life. And so we really want to make sure that the child is doing the best they can in school, because you don't want a child who's sitting at home, I can't do anything. You really want to make sure that that child is engaged in school. So great point. In front here.
I probably don't need a mic. Okay, so I am a wife of a CPVT patient, and our daughter has CPVT. Mm-hmm. She's 8 years old, and we were told to no exercise.
Sure.
To limit, but really no exercise. Now, granted, we need to check and see if our doctor's on the board and
physician, a SADS referral. Sure.
Is she aware of SADS Foundation, etc.? And I could have heard you wrong, but you said there's a list of activities.
So
that's changing, and
so the list of the
mom, I have problems.
Sure.
Just being you can't do anything.
Yeah.
You cannot run.
So this is where I would get, speak. 1, do your research on your provider. And 2, have the discussion, because just like we were talking a lot yesterday about restrictions and sports and things like that, we can work with families in most instances to provide them activities that they can do that can be safe. And so I would work with your provider and make sure that you have an expert, and 2, you make sure that you're having these discussions together. So it's important to, because it's hard to say you can't run. How can you tell an 8-year-old you can't run? I mean, that's just, they run all the time, right? So I think working very closely with your provider and having these discussions are the most important thing. And so that what I was talking about from the list is there's a whole classification of sports, and there is a lower risk classification of sports, which includes bowling, riflery, curling, golf, cricket. Did I miss one? Anyway. Sure. So these are the things that you want to discuss with your provider. What are the parameters? Because you can't just say you have to sit on the couch all day. That doesn't work, right? So work with your provider on how to do exercise safely and how much exercise is safe. So I think that's important discussion. And Dr. Ackerman has, and Dr. Brule and everyone in this room, physicians in this room, have these conversations with their patients all the time. It's not one size fits all. We work with each patient individually to have these discussions. And I think that's what we're seeing change over time. We're not saying, oh yeah, everyone can just go play sports now. We are recognizing that different genes, different patients can have, different restrictions and different recommendations. So I'd really have a conversation with your provider on that, making sure that they're an expert first. Great question. All right. Well, thank you for being here today.
Thanks, Bryn. We're a little bit ahead of schedule, which is great. We always love to do that. But we have a short time for us to stretch our legs, take a quick break, go to the bathroom, which is just around the corner, refill your coffee, and then we'll come back in about 20 minutes to get restarted. Pushing ahead with the agenda. And next we have Dr. Charlie Brule, who came to us from Washington, D.C., Children's National, and he's going to talk to us about devices.
All right, thanks everybody, and want to add my thank you to the SADS folks and the Texas Children's folks for inviting me here and having a nice full audience of family. It's a lot different than when we're doing the virtual Zoom SADS webinars, and you have no idea if there's 2 people or 200 people on the other end of the webinar till you're done. Yeah, I'm from Washington, D.C., and that picture on the left of the Capitol in the background where all your crazy congressmen and senators work is walking distance from my hospital, Children's National. And we're not going to talk politics, but advocacy. It's important that you can advocate for people with SADS conditions and think about how much funding they get from the government. It's way too little. If you talk about diseases like cystic fibrosis, which is much rarer than SADS, they get about 25 times the funding that SADS conditions get from Congress. So advocate for your conditions to your congressmen and senators when they're done running for office. So we know that most devices aren't designed for children. And here's just a few examples of patients. There's one, the little tiny preemie in the top with a temporary pacemaker that's actually bigger than the baby. The infant there with a sternotomy to place a pacemaker, and my cute little patient who I took care of in Washington is now cared for here in Houston by Dr. Miyake. The little ballerina there, you can see actually on the side view better, that pacemaker there in her belly that the parents put the arrow on is just too big for a little ballerina's belly. And so we're going to talk today about devices and focusing on devices for children. And at the end, if you don't like seeing blood and guts, I'm going to show a couple of videos at the end. They're piglets, they're not babies, but if you don't like to see hearts in motion, you can just turn away. Or if you had bacon, then maybe you don't want to see the piglets either. So first device we're going to talk about are loops and recorders. So we're going to talk about loop recorders, and they've gotten a lot smaller. So all of the manufacturers have really downsized from what used to be the size of like a pack of gum. That's what we used to say, that it's about the size of a pack of gum for the Reveal XT. And now all of them are essentially injectable and quite small, and that has led to more uptake, meaning we're using them in more patients to make the diagnosis and figure out what the rhythm is without having anything in or on the heart. And there's been studies showing that these are useful in pediatrics. We can demonstrate either the heart rate going too fast or too slow and figure out then what the more accurate treatment is. Does the patient need a pacemaker? Does the patient need a defibrillator? Does the patient need medications? And several different programs have shown the utility. So these are pediatric patients that had devices. I don't expect people to be interpreting the electrograms, but showing different types of tachycardias and bradycardias in children with devices. So these are useful diagnostic tools if you can't figure out what's going on from the outside. Typically, we'll use external monitoring, Holter monitors, patch monitors, things like that, before putting in an injectable monitor, but they are quite useful. And then pacemakers is the next size up. So in children, the standard way right now to put pacemakers in is either transvenously through the vein, the way that most adults get their pacemakers, or epicardially in the smaller children where we think the veins might be too small or they have concomitant congenital heart disease. The surgeon has to open the chest like you saw in that first picture and sew the wires onto the heart. And in those cases, the pacemaker typically ends up in the belly. And so those are the sort of standard ways. You can see in the transvenous picture, we make a big loop to hopefully allow that lead to grow as the patient triples their size in the first year of age, which is different than when an adult gets a pacemaker and they're not still growing. And defibrillators. So ICDs have come a long way. This is a plaque I got from a company and an x-ray of a child who got a defibrillator. It's a 10-year-old with long QT syndrome who ended up drowning. And nowadays we know from Dr. Ackerman and from others that swimming is a risk factor that is one of the ways that patients with long QT syndrome present. So she was 10 years old, had a cardiac arrest, went to the bottom of the pool, got resuscitated, fortunately did great, and I put a defibrillator in her in 1994. At that point, she was the smallest patient in the country to get a defibrillator. Nowadays, we're putting them in babies if they need them, but defibrillators have come a long way in the past 30 years. And I showed this slide yesterday in the conference for the providers, and ironically, this young woman who's now in her 40s has outlived the company. That company, Telectronics, has gone out of business. So. And now we even have guidelines and expert consensus recommendations from many of the people in this room have come up with guidelines for who should get a device if they have an inherited arrhythmia. So we're going to talk about what's new that's good for specifically for pediatrics, because devices have gotten a little bit smaller over the past 3 decades, but compared to the size of an infant, they're still pretty big. And miniaturization is feasible, but there's not much of a market incentive for it. For people who are in the business world out here, it's hard to justify to a for-profit stockholder company to make a product that might be useful for 50 kids a year. It just doesn't do it for their shareholders. And children, because they're smaller, require less defibrillation energy. So for a defibrillator, you could potentially make a smaller device that packs less energy. And the old days of batteries and capacitors were pretty clunky. And so that technology is improving, and the size of the devices has progressively gotten smaller over the past 3 decades. But again, they're great for teenagers and adults in terms of that decreasing size. But if you're a 5-year-old, it's still pretty big. And the biggest problem with devices, in my opinion, is the leads. The leads break. So this chain link fence, you pull on it, as a kid grows, that lead is not designed to be there for 80 years, right? We're happy if a lead lasts 20 years. But if you're putting a lead in an 8-year-old, you are going to end up having to replace that multiple times over hopefully the next 80, 90 years of life. And as difficult it is to put in, they're even harder to take out because, as you can imagine, they scar into place. And so we end up doing what's called lead extraction, where we pull on the lead and we pull out sometimes pieces of tissue of the heart as we're pulling out the lead. So that's probably one of the riskiest things we do in our field is lead extraction. And so just like Bryn said about going to get your care and your diagnosis and your therapy, probably even more important for getting an expert to if you're getting a device, and particularly taking out the device, because it's risk versus risk. We either have to abandon the lead in place and just leave a whole bunch of old leads as sort of space junk in there as we put in the new ones, or extracting the lead, taking them out, and not leaving those old leads in place. So that's how we have to balance that risk. And so I think the goal is really to avoid putting leads in the veins. And so some of the newer technologies that are coming around over the next few years and are here already are ideas and concepts and devices that don't have leads in the veins, which is the way we've been putting pacemakers and defibrillators in for now 40, 50 years. So we think that the next generation devices are all going to be not through the vein. So sometimes in our field, we have to be creative. We have to do non-standard things. We can't just take what's off the shelf and stuff it into a 6-year-old and hope it works. So we have to use pacemakers that are there, and then we can use some of the technology and make it better. One of the most exciting things that's come around for adults is leadless pacemakers. So as I said, the lead is the most vulnerable part of the system and the most problematic part in terms of taking it out. And so companies hear us, and they've come out with leadless pacemakers that go in through the vein in your leg, the femoral vein, and go up like a catheter procedure, and basically leave this lead on the inside of the heart. Again, I'll show you a picture of it. Those are some of the leadless pacemakers there. They're quite small, and they get embedded in the inside of the heart like a little bullet. Here's a diagram of what it looks like. A little docking mechanism from the catheter that goes in. There's a little screw on the end of it, or some little tines that sort of grasp it into place like that. You can see on the X-ray where it sits on the heart there, right there. And there's no leads or wires. And there's another manufacturer, probably the most commonly used one, and that's the one that's got the little tines that hook in on there. Used in thousands and thousands of adults since this was introduced now 2015 and 2016 for the two different products. So now tens of thousands of adults have gotten these devices. And here's our data in pediatrics. There's really not much. There's a few cases here and there. Here's my partner, Libby Sherwin, put this one in an 8-year-old. We've done a handful of cases, I think less than 10, somewhere between 5 and 10 cases in putting them in smaller children. There's a couple of case reports out there in the literature. I like this one. This is a case from Israel. They had a loop recorder in that showed this long pause. So you can see the heart rhythm sort of stops. There's no beat there for about 7 or 8 seconds. And so they realized the child needed a pacemaker. And so they put the pacemaker in. What I like about this picture, this is the leadless pacemaker here. And on the skin, under the skin, that's the loop recorder. So they're about the same size. One's just in the heart and the other one's under the skin, but on the X-ray, they look exactly the same. One of the pediatric electrophysiologist has been advocating for using this in really small children, putting it in through the neck vein, the jugular vein, and putting it in essentially from above. I don't think that this has been widely adopted. He's been doing this, and I think it's novel and innovative. But what we have to worry about with putting these devices in children is how we can get them out, right? Because again, if you put this in a 70-year-old and it lasts 10, 15 years, maybe you need a second one when they're 80, 85, and you can leave the first one in, put the second one in next to it. But in an 8-year-old, again, who might need pacing for 80, 90 more years, and these devices last 8 to 10 years, 12 if you're lucky, they're going to get a lot of devices. And I don't think you can put 6 or 8 devices inside the heart and just abandon them. But the anticipation is there will be tools and techniques to get them out. Right now, they're sort of modified. Here we're in Texas, so I'll show you a lasso. There's some different snares and ways to pull them out and grab them, but it's going to be difficult. It's going to be difficult to get these out because the scar tissue grows around them, and it'll be hard to get them out. So that's leadless pacing. I want to show you another novel thing that we and others have done, which is putting pacemakers in without X-ray. 99.9% of patients get their pacemakers put in under X-ray, and that's okay. You don't use a lot of X-ray, and most of the time it's fine. When you're pregnant, it's probably not a great idea to get X-ray, and this person's probably further along that it doesn't matter because she's probably going to have the baby the day after this. But that's actually not that's a friend of mine. That's not the woman who got the pacemaker in the photo. But the pause is the patient who got the X-ray. It's a teenage girl, teenage pregnant girl who had a long pause and fainted and had congenital heart disease, and we didn't want to use fluoroscopy. And so I'm going to show you the way we do catheter ablation for a different type of procedure that we do. And using those tools and technologies, you can see the pacing lead going down using sort of what's called magnetic guidance. It's sort of like Waze or the GPS in your car. And you see the catheter moving through the heart without using X-ray or any other radiation. And you can see that right now it's going up to the top of the heart, moving down and coming down to place it in the bottom of the ventricle where it can sit and be able to pace this woman. And again, being able to do this without using X-ray. Now, it was sort of a one-off to do it on this patient, but I think in the future, that's what we're going to be doing. I think X-ray is going to be obsolete. There's all kinds of other ways to image besides X-ray that are safer and aren't adding radiation, which is a risk, again, to people, especially if you have congenital heart disease and you're getting other kinds of exposure. You're getting CAT scans for one thing, you're getting X-rays, chest X-rays, you're getting post-op X-rays, you're getting X-rays for your pacemakers. So I think eventually this will be the way that devices are put in the future. And so then after she delivered, okay, where we go. Here's the X-ray of what it looked like, and you can see the X-ray showing the pacemaker and going through in the tip of the bottom of her heart. Now, subcutaneous defibrillators. This is not a new idea. So I thought of this now in 2000, so probably in the 20th century, and two other groups over on the other side from two different countries. So 3 people in 3 different countries had this same idea to do subcutaneous defibrillators and use them in children to avoid putting defibrillator leads in the veins or having to put them on the outside of the heart. So we came up with this idea, but we weren't smart enough to patent it. And so now there's lots of different ways to put pacemakers and defibrillator leads on the heart, but this company was smart enough to patent it 15 years later, the subcutaneous implantable cardioverter defibrillator. So basically an ICD that goes on the side with a wire that just comes under the skin next to the sternum and runs along there, like you see in the picture behind me and on both sides. And so the advantage is there's no wires in or on the heart, and it sort of acts like an AED, like an automatic external defibrillator. It's sort of like having pads on here and here. It has this coil here and the can here, and that acts the same as having an external defibrillator, just happens to be under the skin rather than on top of the skin. And so it has lots of advantages. Again, also doesn't need X-ray and less strain on the lead. And if it breaks and you have to take it out, at least it's just right under the skin. You don't have to do a lead extraction like I showed you earlier. These devices are still pretty big. This is a 10-year-old patient with hypertrophic cardiomyopathy, weighs 32 kilos. That's about 68 pounds. So pretty small child. And you can see cosmetically, it's a bigger device than the transvenous devices that we implant right now. And here's a picture of this guy was playing a video game with his brother, complained of dizziness, loss of hearing, and chest pain. And what we see as the electrophysiologist is this is ventricular fibrillation. The subcutaneous ICD shocks him and converts him out of the dangerous rhythm, and he goes on to continue playing the video game. So the devices have gotten smaller. Always first generation devices are big. It's just like anything else. Your first computer was really big, and now you got really tiny computers. The first generation subcutaneous ICD was big. So the second generation, which is where we are now, is a little bit less thick, a little bit less heavy, and lasts longer. Lasts about 7 years, and has the remote monitoring that we use for other devices. So it is improved and a bit smaller, and I would imagine that it'll continue to get a little bit smaller. And we have to do some customizing, like I showed you that picture with the scissors. Here on the right side shows where you had to bend it so that because the coil was too long to go up and down in this small heart. And in this child who has dextrocardia, meaning the heart's on the right side, they put the defibrillator on the right side. It's not just that the X-ray is reversed. And then there's some newer things coming out. I'm going to show you some newer devices. This is what's called a substernal defibrillator. There's a little tool, a tunneling tool here that goes just under the sternum, and the coil goes under the sternum there. And then the device, similar to the subcutaneous ICD, goes on the side there. So that's another manufacturer's idea for a defibrillator that doesn't have a wire in the heart. This one was really exciting. I saw this thing called the string defibrillator, subcutaneous string defibrillator. I talked with the inventors and the manufacturers, and it just goes under the skin, around your belly. It looks really great. It was presented at one of our meetings, the Heart Rhythm Conference, now in 2017, as a late-breaking, exciting abstract, because they put this in some patients, and we haven't seen anything since. And I've looked on the company's website. It's still where it is now. So if it works, it'll be great. But it's been 5 years since they presented it, their first patients at Heart Rhythm. So I'm a little bit less enthusiastic that it's going to actually make it to the market. Okay, so now I'm going to show you some of the work that I've been doing over the past decade on miniaturization of pacemakers. And our goal is to put them in without having to open the chest or put wires in or on the heart. So these are little piglets. These are about 3 kilograms, so 7-pound, cute little piglets. You can tell they're not humans because they got 8 nipples. And there's a little port there with 2 holes, and one hole, a camera, microscopic or thoracoscopic camera, goes down there so you can see what you're doing, which adds safety because you can see what you're doing at the other end, because the other hole, a sharp needle is going to go down to allow us to put a wire in. So for those of you who don't like to see moving parts, I'm going to show you a video next. And so this is what it looks like from the inside. So that little needle goes through the port. The camera is what we're seeing it with, and goes into what's called the pericardial sac. I see a couple of people looking away. It's okay. And so the needle goes into the pericardial sac right next to the heart, and we put a little soft wire in and around the heart. And the nice part about being able to see it is you can avoid anything we don't want to damage anything. So then a plastic sheath goes in over the wire. The needle's out, and it's just a plastic sheath in there now. And we can put a defibrillator lead and wrap it around the heart. And by just rotating it, we fixate the defibrillator lead to the heart, pull out the sheath through that little port, and that's the end of the procedure. And you can see just a little small hole in the pericardium, which is fine. You don't even need a pericardium. You can take the whole thing out, but it's just a little hole in the pericardium, and this whole procedure takes less than an hour. And so that's one way of putting it in. And you still need to have a device, so that lead would be attached to whatever manufacturer's device there is, whether a pacemaker or a defibrillator that would go in the belly. And our next step is to design a lead that actually goes through that port, so you don't even need to use an incision. And here, this is one of those prototypes of a pacemaker. It looks like one of those leadless pacemakers because it is. It's one of those leadless pacemakers that we put a cap on it and a little tiny, what we call a leadlet, which is about this long, that has a corkscrew on the end. And the corkscrew goes through that port that you just saw, screws onto the heart, and that's it. That's the whole pacemaker in the back. It just goes in under here, and it's been done now for probably 50 piglets. So if you have a piglet that needs a pacemaker, I'm the guy to do it. We haven't done it in any patients yet, but we've been to the FDA twice now, and we've been given approval to do it in 5 newborn patients who will need it. So we haven't done it yet, but the FDA and the National Institutes of Health have given us approval based on the benchtop and animal work to do it. So probably 2023, maybe a year from now, we'll have our first patient, but it will be very selective in newborns or tiny patients who really would be at higher risk of getting a standard pacemaker. And then finally, our next step, which we've just started, and my team has just started, is rather than that port that I showed you, which is small enough, the port's sort of the size of your finger or something, it's pretty small. We're trying to do it completely injectable, so just a needle, get rid of the whole port, because the port was really to show you the camera so that we could see what we were seeing. And so here it's really tiny, and the camera actually goes through the needle. This is unpublished, so you all are really the first ones to see this. And again, I'm going to show you a little video, so turn away. And so this is you're looking through the needle. This is the size of a needle. You're looking through the needle at the chest. That's the bevel of the needle there. There's the left lung, and there's the heart. Okay, and there's the heart. You can see the heart beating, and the needle's going up to the heart. Carefully, carefully, carefully. And then we tent the pericardium, that little lining around the heart, and we push a little harder and eventually get into the pericardial space. And sorry, keep going. Okay, so there's into the pericardial space, and now you see the inside of the heart. You actually see the heart beating. And that little flap there is what's called the atrial appendage, the left atrial appendage, and we can put something on there. We're just, this is all new, and so that's our goal, is to go from that scope that I showed you. We had much clearer picture through the bigger port, and then a first look at trying to get it through a needle. So as the technology improves, I think it will become a reality. Because pediatric electrophysiologists, we have to be creative. The big companies aren't going to make us a pediatric pacemaker. It's just as I alluded to earlier. There's no market incentive. They're all for-profit companies, and it's nothing against them. They have a fiduciary responsibility to their shareholders to make a profit. That's their goal. It's great that they're working with us to try to do this, but it's going to be organizations like SADS and the PACES and Heart Rhythm and individual investigators to try to do this. Now, so 50 years ago, we were watching TV on big devices like that. I can barely remember as a kid looking at a TV that looked like that at my grandparents' house. And now you can watch TV on your phone, right? So miniaturization is feasible. That's 50 years of improvement from that TV to your phone TV. It's pretty reasonable to expect that defibrillator is from 1991, so 30 years ago. It is pretty reasonable to imagine that 30 years progress, maybe in 35 years, we'll be able to be delivering these devices either through a port or even better, through a needle. So I want to thank my team here and the support we receive from philanthropic organizations and the federal government and one of the device companies to help us do that work. And happy to take any questions about pacemakers, loop recorders, defibrillators, or anything.
I had a question about the scar tissue on the outside of a defibrillator. So my husband, he likes to lift weights.
Yeah.
And so his doctors told him, because sometimes he'll have like sharp shooting pains, but he's always said it's because of the scar tissue and, manipulating that. And does it create more when he's lifting weights or?
Well, I'm not going to talk specifically about you, but in general, the more surgery you do, the more scar tissue will be formed. And so bigger surgeries end up with more scar tissue. And everybody's different. Some people form a lot of scar tissue. When we go back in and reoperate, sometimes we're amazed to see calcified, what really hard scar tissue. And sometimes, even after 10 years, it looks smooth as can be. So there's a lot of individual variation in scar formation around the pocket of the device and around the leads. And so it's somewhat unpredictable how much scar an individual is going to form. You sort of know some people are more prone to keloids, and you see, if they got pierced ears and they got a big lump there, that they're going to be scar formers, right? So you might know individually whether you have more or less scar formation, but in general, it's the smaller the less you do, the less scar hopefully will form. There's two in the back, one in the back and then right there.
That was a good question. I'm not a person that keloids typically. I've had cesareans and everything else, but where my ICD is implanted, I have a keloid.
Yeah.
Is that normal?
It's common. I don't know if it's normal, but it's common. And there's lots of things we can try to do to reduce that risk, but they still happen. Some people say that the vertical scar might be better than a diagonal or a horizontal scar, but I'm not convinced. I've seen keloids in everybody. I've been told by some patients that the creams that they pay a lot of money for, like I'm not advocating any specific brand. The only one I can think of is Mederma, but a lot of people say that those help reduce keloid formation. So or steroid creams. I just tell my patients wait till it's fully. Wait a couple weeks before putting those on. But some people tell me that those work. I'm not advocating for them because I don't know scientifically.
So the new IED or ICDs you have, do they still record data and still transmit the smaller ones?
Yes,
Okay.
They do everything that the standard devices do. Yes. It's interesting. Two of the questions about scars are interesting because I tell my trainees, make the scars look nice. It doesn't matter whether it's a teenage cheerleader or a 40-year-old man. They make the scars look pretty because that's all your patients will see, right? They don't see all the hard work you're doing putting the lead into the some branch of the coronary sinus in the left ventricle, to get technical. They don't care that was the hardest part of the procedure. The easiest part's closing it up. But I always tell my trainees, make it look good because that's the only thing the patients will see and have to live with.
Or you can be like him, and they don't look wonderful, but they're on both sides and all over the side.
Yeah.
And then pretend it's a gang fight. Or like,
Be proud of your scar.
Yeah, so I've had 5 units. I have had the lead extraction, and it blotted off. What is it, the subclavian? Is that what it's called? And so they had to move it over to the right side. So I've had some experiences there. But I did notice when you were talking about some of these pacemakers and defibrillators, they're not combined, right?
They are combined. So
they are.
All defibrillators have, these days, pacemaker technology in them. So all defibrillators can pace, but all pacemakers don't defibrillate. So yes, all defibrillators now have all the pacing capabilities in them, and your physician will decide whether you need 1 lead, 2 leads, 3 leads to pace, depending on which chambers they want to pace or be able to sense the rhythm from.
and the battery of those compared to, okay, so the battery of the defibrillator and pacemaker compared to the pacemaker.
Yeah, the main difference is that the reason that defibrillators are 3.5 times as big as pacemakers is because they have to deliver a shock. And so you have to deliver what translates to about 750 volts. It's 40 joules, but it translates to about 750 volts. So you need a capacitor in there, a big battery, to be able to charge up and store that much energy. It's kind of like a Tesla. You have to store that energy in the battery to be able to defibrillate. And the pacemaker just has to pace, so you're only pacing at 2 to 5 volts or 7 volts at most. And so you can use a much smaller battery to last the same roughly 10 years. I think they're cluing me that
No, we're just getting
okay. Okay. In the back.
I'm on unit number 1. I'm 33, and defibrillator. I'm wondering if the technologies improve over time and it's possible to get something smaller. Obviously, that's a big expense, but how easy is that to remove and replace the entire thing? Is that even going to happen in my lifetime, that sort of thing will be?
Yeah, I mean, again, I'm going to speak in general, not about you specifically. The devices, the batteries usually last, give or take, about 10 years. So maybe some might only last 7, some might last 13. But you're young, or someone young that's your age, hypothetically, since I'm not talking about you, will likely have multiple changes of their device, hopefully, meaning you're going to hopefully live decades. And when the time comes to replace it, they can replace it with a smaller device, and that's usually the time. I think it's pretty uncommon for people to electively replace it because the smaller device became available, unless they're having a lot of pain at the pocket. So I wouldn't electively replace it just for a smaller one.
I have a question. Is it common that the devices heat up?
Should
they not be heating up?
I wouldn't.
Feeling, like, because a couple of times you would feel heat around the area.
Yeah, it's not something that I'm commonly heard. That once they're in, I don't think that they would typically heat up. They're metal, so they will conduct and store the heat, just like your container of coffee. If you put it in an aluminum container, that aluminum heats up. They're made out of titanium, and so they will draw in the heat. But I haven't heard that as a concern or complaint from my patients or my piglets.
I've had five units, and I pace about 95% of the time. So I've never felt heat.
Have you heard that? Yeah, so I don't think that's a common sensation.
You're in an MRI.
An MRI, yeah. In an MRI, that's a good point, Dr. Miyake. If you're in an MRI unit, they can heat up, but in general, you're not living in an MRI. So
we'll give you the final question for Dr. Brule.
Do we still have the same risk for traveling if they travel through the airports, for example, like kids? Do you still have the same risk?
That's a good question. So the question is the same concerns about electromagnetic interference. So the pacemakers will sometimes pace when they're in a high magnetic field. The defibrillators will turn off the ability to defibrillate when they're in the presence of a magnet. And so it's okay to walk through those metal detectors. We advise that you don't put the handheld wands right on top of the device, so that if they don't let you walk through, to get a pat down rather than put one of those wands over it. And don't stand with your arm, that if you have your defibrillator here or pacemaker, don't stand with your arm right over. That happens going through like store security. So if you're in the mall and they have those big towers, it's fine to walk through, but don't lean on it and just stand in the entryway of the store, because some people have passed out from their device turning off during that. Not if you walk through, but if you're standing right next to it.
Your phone in the pocket.
A phone in the pocket. Yeah, all of the companies have put in filters for your phone, but we still advise not putting it in your left breast, in the pocket where your device is. Most of the companies have put in filters, but like my phone, this has a little metal tab. a little magnetic tab on it like that. That probably is too small of a magnet to make anything beep, but anything magnetic you don't want to have within 6 inches of your device. So if your device on the left side, don't use this pocket to store a phone. But that's probably being overcautious, because now all of the companies have cellular filters in. It's more for magnets. Same thing with giant speakers. So if you're at a rock concert, your kids are at a rock concert, that's fine. Don't let them be right up in the front row, because they'll go deaf. And the speakers have the big speakers at concert venues are magnetic. Thanks very much.
Thanks.
Sure.
What's that?
Do they have to leave? Okay.
Well, maybe before we start the fireside chat and continue collectively, let's give a big round to Dr. Charlie Brule, Dr. Andrew Landstrom, and Bryn. That was great. I just came up from the teenagers chat, the private chat, and I can only say you have amazing kids. So I won't tell you which children asked about which, or young men and women asked about which, especially which one asked about getting drunk. So that you can just leave it to wonder which one of you has to be most concerned about alcohol. But they had great questions, and Madison and is it Kian? Cian.
Kian.
That's a great name. I love that. And Cooper and all of them. Reese and Reese's sister. So just great kids with great questions. They're really listening in the office. So always be aware that they pay better attention than what you might give them credit for. So I think we're open to anything and everything. The way we do this is just like with the kids session, there's no question that's unacceptable. So we just get a chat. You get a chat, I think, till 12:15 with them. You'll see me leave right at noon, because I guess if you're 2 minutes late, then Uber starts charging you or something. But I did practice how to get to the Uber pickup spot. So I did a dress rehearsal, so I can run it right up to the edge of time. So anything you want.
We talked a little bit about devices before. Would you guys be comfortable talking about on the retail devices like iWatches and other I guess commercial products to monitor heart rates and ECG, and how useful or not useful you think they might be?
Yeah, like you're suggesting, there's a lot of movement and technology for home monitoring, heart rate, rhythm, those kinds of things, and they're getting better. The one caution is several of those devices may be made for adults. And so you want to make sure that what you're using is something that's a reliable, vetted thing. And I'd encourage you to talk to your physician about the specific one. They can, many of them do a very good job at capturing your heart rate. Some of them, like the Apple Watch, can give you the ability to capture your ECG. I think it's version 5 and beyond, or 6 and beyond, or something like that, and send it to us. So, but that's all they do, is really capture the rhythm, and then it allows you to transmit it and then engage your physician to talk about what it found. But yeah, there's a lot of movement, and they continue to get better.
So I'm conflicted. So Mayo Clinic and I have a relationship with AliveCor. So they're a company that has produced the device CardioMobile. That device is the one you see on commercials you put your fingers on, and the newest generation you put your fingers on and then on your knee. That's the 6L. That's FDA, that one. That's FDA approved for a long time for a rhythm that we don't talk about here called atrial fibrillation. What we've done is we've created the artificial intelligence QT detector to add to it, and that got FDA cleared in April. So it's the first time we've had that, but it's cleared by a prescription, which is really cumbersome right now. So you can't put it on and see your QTC readout. Now you can put it on and get the trace and send to us for us to take a look at. But the next step is to try to convince the FDA that you don't need a prescription for them to turn on the QT feature. And I think where that's going to have a role, not even so much in patients with long QT syndrome, but you can think about all the settings in psychiatry where the psychiatrists are prescribing medications with a QT signal, methadone clinics that do QT monitoring or could do QT monitoring to see if you're actually taking your methadone. So there's going to be a lot of applications for it. But for our long QT patients, you could check yourself if you're under the weather with vomiting and diarrheal illnesses and say if your QT is lengthening, maybe you better be getting your potassium checked. So there's going to be some ability to monitor your QTC. And I think right now it's in that awkward requirement of a physician prescription to get that feature turned on.
See that expanding to other measurements like QRS duration?
No, well, I don't know if they are in the works for using it to make those kind of measurements. It's just the so-called deep neural network QTC detector is the feature that got approved. Yeah.
So I don't have any relationships like Dr. Ackerman. And for those of you that have worked with me, it really depends on your child and your disease or your, and also what's going to work for your particular family. So for example, I use CardioMobile. It depends if you're having some symptoms. I've used it in a Tango 2 child because QTC is concerning. Now, we didn't have this feature, but we used it in a different way. I think that in particular, our goal is to make sure that your child has as normal life as possible. If that device helps, then perhaps, for example, if it makes them feel better, if they can, they feel safer, for example, if they're jogging or if they're running to keep their heart rate under something, maybe we'll use it. But if that makes them anxious, because every time they're going to use that and that's going to make them anxious, that's not the right person to use it. So it really needs to be tailored to your specific child and make sure that they understand that they're not getting more anxious because they're using this device. So again, it's hard to say that there's one thing that we use for all of you. We might not use anything, but work with your own physician and figure out what works for your child and your specific disease. We have certain monitors, for example, Dr. Brule showed you the Link monitor, where we really need to track you. And if that's something we need to do, then that's something we might have already talked to you about. But that's the one that really gives us everything. It really monitors you much more closely. If you have a device, we're already doing that because it's monitoring you. So again, it's tailored to each family.
Yeah, and I think
I've actually. Oh,
go ahead. I was just going to say that Dr. Miyake brings up a great point. You know, the purpose of why you're having it on. I have several patients that have either a watch or a monitor, and it makes them more nervous. And so, you know, you get calls about they're at school and their heart rate got a little bit fast. And so for some kids, it just adds to anxiety. And so I think the purpose of why we're having it on is an important discussion.
Yeah. Without a doubt, I've told more of the patients to get rid of their monitoring watch than to go get one. So, which means, except for what I think is going to be a bit of a change with QT monitoring in certain diseases and actually not even long QT syndrome, I don't need to give my well-treated patients a heart rate limit. So somebody asks, what's the heart rate that I can't go above? And I'll say, oh, how about 250? You know, because I don't want them thinking that they're somehow tethered to a heart rate. And so there's part of that anxiety thing that's very, very real. So.
And I also think you as the parents know your children better than we do. And so you'll see that, you know, when you work with us a little bit longer, we get to know your children too, but you play a really important part in helping us figure out what's right for your child because nobody knows them like you do. Or if you're an adult too, you know yourself.
Total different subject, but more CPVT specific on the LCSD procedures and just how have they been, I guess, better outcomes? Are we seeing better outcomes with that procedure as it's been done more and more often? And when is it being recommended to be done? Is it becoming more of a common part of the treatment plan, or is it still reserved for people that are having more breakthrough? Just looking down the future with my daughter.
Yeah,
and
so great question. I'll start with it. We do more denervations than anywhere in the world. It was first done in 1974, so it's not a new thing. What became a new thing for the procedure is converting it to a minimally invasive with the video cameras and the video scope, so making it endoscopic or videoscopic, if you will. It used to, so you can see the evolution of it. It originally was reserved for, I have really, really bad disease. The treatments aren't working. My defibrillator's firing. Can we make that less likely? Not zero, less likely. So anybody who says denervation is a curative surgery is wrong, because that's not what the truth is. But it started with that group of patients, and that's where we saw, and Peter Schwartz revealed the strength of the signal in 2004. So we know its therapeutic efficacy for a long time now, almost 20 years with good signal. And then over time, it shifted. So right now, I have two groups of patients basically who come for denervation for long QT or CPVT. There's no role for it for Brugada, for example. So I met one Brugada family from the teenagers. So only long QT, only CPVT. There's some use in a different disease, but is really twofold. Bad disease, treatment's not working, stop my defibrillator from shocking if we can. And then the newer group over the last 20 years has been not bad disease, but thank you very little, I hate life on therapy. So not bad disease, but bad beta blocker experience. So wanting and seeking a better quality of life. And right now in our program at Mayo, it's the half and half. 50% are bad disease. 50% have concluded that feeling the way they feel on their current medication therapy is not acceptable. And so they're seeking a way to feel better. So the efficacy signal is absolutely the best in type 1 long QT, next best and really close second in CPVT, third in LQT2, and then the others start to drop off where it just it's not that good from my vantage point in bad LQT3. And so we won't be quick to offer that one necessarily for somebody with tough to control LQT3.
And I do have heard a little bit about the side effects of the procedure. Is that something that's better managed now, or that
Yeah, I think the side effects is a really important one, and to get it right, because what kind of happens in the Facebook world, I suppose, is somebody who's had a bad denervation side effect, or what they've concluded bad, gets amplified in an echo chamber, and it seems, oh my goodness, this is terrible. So I'll set the record straight. The guaranteed sequelae of the denervation is the left hand is drier and warmer than the right hand. That's guaranteed. Has no effect on dexterity, tactile strength, anything. And that's just because the real estate that comes out, the sweat fibers come out with the territory. So that's basically 100%. The look, which is this look where the left side is pale and dry and the right side is shimmering in sweat and red, is called the Harlequin appearance. It's of no consequence. The only consequence is if you didn't tell them and they came in from a workout and looked in the mirror and, So I had one of my denervated patients, she sent me Two-Face for her Halloween character. So she's a marathon runner who thought she'd be clever with the look. So none of them have really ever said, that look, if I would have known about that look, I wouldn't have done that. The 3 to 5% is the droopy left eyelid. And by droopy left eyelid, it generally, if you are that 3 to 5%, you join the 10% of the planet that has a natural droop anyway. So we've done one eyelid lift surgery in our first 400 surgeries. So it's almost never of consequence. So that's a 5%er. The one that gives pause from being too, I would say, let's denervate the world, is post-denervation neuropathic pain. So when you cut those nerve endings and that you leave the raw endings behind, in some people, they feel the pain, feel neuropathic pain or nerve ending pain. That signal of some people is solidly about 5 to 10%. It goes away in everybody. Everybody has a residual pressure point spot. It's about the size of a nickel, where you say, don't give me a shiatsu massage right there. But nobody cares about that. Those who show up with the pain, it's about 2 weeks later that it arrives, and it's in here and in the left arm. And again, in that group, it goes away. But what we're seeing is that 5 to 10% is overwhelmingly occupied by those who dealt with a variety of pain sensitization things throughout their life. So if they have chronic fatigue, fibromyalgia, everything hurts, they'll be the ones calling us 2 weeks later to tell us they got the pain. And then those are the ones, that combination also is a combination that expresses themselves in. So I think the pain thing has gotten an echo chamber bad rap. I mean, for those who get it, it's not good, and we need to figure out some solutions, but it's not scary. And so we've had published a quality of life paper, and the bottom line was everything I just described, the parents and the kids, whether it was a kid who had it or an adult who had it, 95% I would do that surgery all over again. And that's really high satisfaction for the beta blocker. I hate beta blocker. For a semi-elective surgery, that's pretty good. But that's the list of the trade-off. So what's the upside, what's the downside? That's the summary. And each of them have, I know Bryn has sent patients from Michigan, and Andrew has, and Dr. Canner has, and Texas Children's has as well. And you might, if you've seen any other things that I haven't summarized there, but that's, and thanks for giving the time to talk, because that's a key component of the treatment, armamentarium that we have that a lot of places don't have. And that's one of the challenges, and I think that's what I loved about Bryn's talk, is getting connected. So Dr. Canner's a great NEP. If he doesn't have that at his program, he can get on the phone and say, let me get my patient to you, type thing. And I think sometimes in the EP world, every EP program everywhere can throw in a defibrillator. So when you can throw in something, you throw it in. If you don't have it at your center to offer, there's a tendency to downplay it and say, well, I don't know if we really need that treatment option. And you need to have the right kind of physician who would be able to say, we don't quite have a treatment that I think would be great for you. Let's get connected with another member of your team, and we'll do a tag team. And I think that's a real important point that, Bryn, in your talk you brought up.
Mm-hmm. And I think it points to, making sure that you go somewhere where there's that expertise, because when you talk about those echo chambers, you could be not aggressive enough and really try to avoid, the side effects, but not have an effective sympathectomy, or you could be very aggressive. So connecting with places that have good experience and do it. You're in a good spot. Yeah.
I concur.
I don't have much to add. I mean, I think, Dr. Ackerman really kind of summarized. I think one of the things we typically, just in general, we don't usually do this in really young children. So if they're not if they're not in the high risk category, although, things are changing. I think that's what's so important, is having expertise and having someone who does so much, and kind of things evolve over time. So right now it's not our mainstay if you've got a completely asymptomatic child who's well controlled, but it's hard to know. Things are coming. We're doing all kinds of, and I'll talk about some of the research studies, and that's where it goes. And we hear from you guys, what are the side effects? How is quality of life? Mm-hmm. Do we need to think about this?
There's this mantra in medicine now, in precision medicine, right drug, right patient given at the right time. And I think it's really now should be expanded to the right therapy given to the right patient at the right time. And so we, in fact, have over 100 patients with long QT where their treatment program is one-time treatment called one-time denervation, no daily medicine, no nothing else. And again, that's not the every patient, that's the right patient. That certainly would not be a dangerous, spooky, high-risk patient who has a very twitchy substrate. But that might be somebody who has said, you know what, I'm not going to live this way, the way I feel. So we get, so beta blockers also get a bad rap, right? Because the bad rap comes from programs like ours, where if they said I went there to get a denervation because I was the beta blocker zombie, which I didn't invent the term, you all gave me the term, or those of you, including patient from two days ago, he offered up, I'm a zombie. So we have an ascertainment bias at our program, meaning they've already concluded they're a zombie, they've already concluded they don't like life on beta blocker, and they want to seek alternatives. That doesn't mean everybody's a zombie. In fact, most patients, tolerate their beta blocker beautifully and acceptably. And so if you're doing good and you're satisfied, why would you engage a surgeon? So I always say, keep the surgeon in the bullpen, because surgery's never free. And so you have to weigh the trade. Am I content with quality of life on my beta blocker? And if the answer is yes, great. If the answer is no, explore with your healthcare team what the options might be.
Hello, everybody. My name is Matt Lambert. I scared your mom. And I've been diagnosed with prolonged QT for most of my life. Yeah, and just to kind of back up what Dr. Ackerman said, I came and got genetic testing from him 10 years ago in Rochester. And since the age of 12, I was on beta blockers, and it really actually saved my life because I was passing out all over the time. It was scaring me, and I didn't think I would live past 30. And so I went to meet him in Minnesota, and he put me on a stress test, and I was on the stress test, and my heartbeat went up to something like 104, on 12 minutes at the stress test. And he said, "How many beta blockers are you on?" And I think I said something like 120 milligrams of beta blockers at the age of 40 years old. And he said, "How much do you weigh?" And I said 180 pounds or whatever. And apparently I was on 3 times the amount of beta blockers that should have been on since I was 12 years old. And he said, "Do you ever feel sleepy or dopey or tired or whatever?" I said, "I don't know. You've just been describing my life the last 25 years, so I'm not really exactly sure how to answer that question." But he reduced my beta blocker, and the world started moving a lot quicker for me. So, I had to get used to that. But I'm still, even 10 years after, interested with the denervation surgery. And it's something that I'd be considering, since, I've got about 30 years left on this planet, and I want to kind of see what that looks like. So thank you very much, and God bless you guys for all the work that you're doing up there. This is my mom. This is my mom.
I have a lot to say, but consider me a thank you card full of cobwebs, because Matt is 53 years old now, and his fainting, quote, quote, started when he was 3. And my compliments to all of you gentlemen, scientists, parents who have lived through this wilderness, as I called it, because when in 1973 there wasn't one soul who knew anything about the term QT. And to hear what you all are talking about today is like some kind of miracle just burst out of the sky, because I'm still talking about it everywhere, but I can't tell you what I feel that your strides have been, and along with Dr. Ackerman and Dr. Vincent and all the other gentlemen, who just to hear what you're talking about is like, what an amazing accomplishment you have made and changed so many lives. And I'm a blabbermouth to contend with, but yesterday on the plane, the lady sitting next to me was reading a book I was interested in, and we started talking, and I told her where I was coming, and she pulled over her blouse, and she had 3 big scars from stents, and she told me what she had behind her breastbone or something, and they couldn't find, I can't remember what the name was, but she was sitting alive next to me. My son is sitting alive next to me, and thank you all for continuing it. And God bless you. And heaven only knows what the future will hold. And lots of health to all of you and a good mind to keep smiling through it all. And thanks, Dr. Ackerman in particular, and Dr. Vincent, of course. Thank you all for letting me speak. Okay.
Okay, we're just getting warmed up, so these are amazing questions. Thank you, Nora.
You gave me tears in my eyes. My son is a patient of the wonderful Dr. Mayaki, and we just had an appointment recently, and Dr. Mayaki told us to come to this, and she wanted us to ask you a question in the fireside chat. So,
it's a setup.
It's a setup.
No.
She's testing me, but I have to interject before you ask. I like that, the wonderful Dr. Miyake. I think that's a movie. I think we should make a movie.
There you go.
The wonderful Doctor. I like the way that
Who
sounds.
did I tell you to come talk to? The expert.
But she definitely wanted to kind of, because we're in the variant of unknown significance, that kind of gray area.
Yeah.
And my husband's dad died of a sudden something when he was 34. So then when my son started having problems, we just assumed when we did the genetic test, because he tested positive, it was going to come from that side of the family. Well, it didn't come from that side of the family. It came from my side of the family. So I also have the same genetic mutation. Yes, thank you. But I've never had, like on stress tests and all that, the same that he has had. So it's interesting because I've learned how important genetics are, and I don't know my birth dad. So I've been on a quest. It's been very interesting. I've found some very positive people on that side of my family who have been very open, and some very negative people. Turns out I do have a half-sister who does have some type of a heart condition and does wear a device. She's not told me very much information. She's not very forthcoming, but I don't believe, according to her, it's a long QT. It's something else. But since we are in that kind of mixed variant, Dr. Miyake wanted us to kind of talk to you about, because, he doesn't need a device, thank God, or anything like that. But we've been on medicine, and he doesn't like taking medicine. Of course, I like him being on medicine because it makes me feel comfortable, and just kind of the research on, I don't even know what I have it here.
You're off, all right.
What is
off
it?
medicine.
Right, but I don't know what the mutation is.
No. I think this is a good point, and many of you probably don't, and so I'll kind of fill in, don't have to deal with this, because hopefully, your variants are known, or what Andrew talked about are pathogenic, so they're known disease-causing variants or mutations, and although it's not, no one wants to have a disease, at least you have that diagnosis. There are families and individuals that deal with this unknown, this uncertainty. Do I have it or do I not have it? And so that's kind of what they're being open about this. They have a variant, and you can see that this, she's talking about her whole family history and trying to get the details so that their physician can make a better assessment. Is this real or is this not? And it's very hard if you don't have all the details and you have somebody who might have heart disease who doesn't. But we take all of this into consideration. Now, if you're and over time, we might put you on a beta blocker early because we're not sure. So this was earlier on, but I think now the data, and I think this is a lot due to Dr. Ackerman, so I wanted, to assure that if your QT is not that long, we don't have any definitive evidence that you have disease.
Right.
Then you don't necessarily need to be on a medication. And that hard part is taking it away, that safety. And I think that's where they're at.
Yeah.
And we have taken it off, and he does not meet your criteria. He's kind of always been on the border. I don't know if you want me to tell how much you want, but on the borderline. And so and Dr. Ackerman has specific criteria, and he does not meet that now. That's why we took it off.
I think the general is, there are cases where everything is straightforward, right? We know which page book to turn to, and we know now, like Nora was saying, compared to 50 years ago, we now know exactly how to read from that page, and then it's a matter of executing the game plan. And the future game plan is getting added, and the future is really exciting. The timetable's not going to be as fast as what you want, so we need a bit of a reality check as to when gene therapy is going to arrive, if it works, and I can give you a sense of that if we have time. But I think in cases like yours, where the story's not hanging together to your satisfaction and to Dr. Miyake's satisfaction, what you need is I would say, a tenacious pit bull-like detective who just sinks their teeth into the information and says, I'm not satisfied. So I always start back at first principles and say, do I even think said person has a disease? And I forget about the genetics. And if I'm not seeing disease, I'm not treating. And then I work to say, okay, what was that thing? Because I was expecting it from that side, but now it's on this side. Now I have to make a rendering. And the companies say it's uncertain, but we need to be forced to say, they called it uncertain, yep, we're stuck. Or no, they called it uncertain, I'm calling it benign, and let's move on. Or they called it uncertain, and like that, I elevated it to pathogenic because I know stuff that the genetic test company doesn't know, like who am I seeing? So you have to make some commitments and then execute the plan as best you can, and then reassess. And I think that's an area, like for example, if you're a sudden cardiac arrest survivor and you don't have a name of your condition yet, what we see all the time is that the adult person who implanted it being the box, they're kind of done. The detective work ends. You had your cardiac arrest, you got your defibrillator, the search for the answer is over. And I say hogwash to that. So our approach is, yes, you might have gotten your device, but we ought to keep on trying to figure out the why. And the why may never happen, the answer to the why. But if you're getting an answer as, we don't really need to do an evaluation on you anymore, we just need to check the machine, to me that would be a clue from Bryn's talk, as maybe we don't have exactly the right healthcare team assembled, because that should not be the answer that you should be given. Great question. Next.
Actually, I have a kid of Tango 2 mutation. He's about 15 years old now, whom we lost his brother on 2012 in Saudi Arabia because of heart rhythm. So he's on device now, which is a pacemaker. And when they installed it on 2012, they told us it's going to be for about 7 years, the battery or so. Since we installed it until now, it has never been triggered, thank God. Is it recommended to put a pacemaker, in future, or since he's okay since 2012 until now? Is it recommended to replace the battery for him or no?
I'll give you one. So for that one, I would be phoning a friend, and that friend would be the wonderful Dr. Miyake. Did you like that? Some physicians, you know that expression, stay in your own lane. So I know which lane is my lane. I know which, tricks I'm okay at or I'm good at. So Tango 2, for example, would be a trick where you and your family would absolutely not want to see me because I know nothing about it. That's not my lane. I would be working to get that family, if they contacted us, to the queen of Tango 2, which is here. Okay? So, but the issue in general, to comment on about devices, I don't know your exact situation, but I have a new approach to device therapy, a philosophical approach. And it goes more like this. You may have gotten a device for when you got the device for the best reasons in the deliberations, but I no longer view a device as a forever therapy. I view the device as a for now therapy. And for now, it all still makes sense. But maybe in the future, we learned something and we no longer needed it. Maybe in the future, the dark side of the device reared its head, and we've had every complication under the sun from the device, and now the trade hasn't been a good trade. So I don't know your situation of what you do or don't need, but I think the mindset that has to start happening in our field is just because the batteries do doesn't have to mean an immediate reflexive replacement of the device. Usually it's going to, but incrementally, like Nora said, the knee-jerk reaction of course you're going to have a device forever. Oh, really? Maybe today's knowledge is sufficient that the reason we had to implant it 20 years ago, we have a new playbook that we know how to execute, and today's version of that playbook doesn't even have the device listed in it as a necessity. So I think it's healthy. It keeps you on your toes and keeps from getting stale as physicians and scientists. And it forces you actually. It's easy to say, device forever, turn off the brain, don't search for the reason, just get a defibrillator every time the battery comes due. It's much harder to challenge yourself to say, is the reasons for that defibrillator, the necessity of it, still present? And so I like the for now thinking rather than the forever thinking. Yeah. Oh.
You can go. Okay, so I am going to ask a very unconventional question.
Ooh, I love it.
So back
Madison
in 20
told me you would be. No, she didn't.
She probably did.
No, she didn't. I'm just playing with you.
So I am a survivor.
It was Bailey.
Oh, Jesus. As long as she got her coffee. I'm a survivor. And I experienced a roller coaster back in 2018. I have a defibrillator implant. And since then, I've gone on to do amazing things here in the city. And if you need a SADS advocate, it's me, okay? A poster child. I have a request from you, Dr. Ackerman. The people on my Facebook page would love for me to have a selfie with you because I talk about you all the time. And I have something like a following. I'm a chef here in the city, and I have products available at Central Market. HEB stores, and I have a request, a picture with you because I have spent the last 4 years of my life watching you virtually, and I want to share that with my friends and family.
Wow. Unconventional indeed, but it depends on the two if they would say permission granted.
You should do it. Yeah.
Please grant me permission. I can do it before you go so I don't make a big old scene, but I know you have 10 minutes left, so I wanted to make sure I asked
so
that.
when you see me heading to the door,
I'm going with you.
You go with me.
Got it.
Okay. We grant her that? That's good. Okay, next question, everybody out there. Embarrassed, flushing me.
Yeah, hi everybody. So Dr. Ackerman, you know about our child, and we are with wonderful Dr. Miyake for a long time. And we have seen you last year. So my question is actually similar to this gentleman. And, my son, he has a pacemaker for like 9 years now. And he didn't receive any shocks, I guess. And so at this point, first it was diagnosed with CPVT because of some COSQ2. And now I think it's like an unknown issue. But how we gonna decide, or how are you gonna decide if it's an unknown issue? But he is a cardiac arrest survivor as well. How we gonna make sure that we want to remove the device or we want to keep it?
Yeah.
Since the reason is unknown.
Yeah. In general, and we have more than the 15 minutes. I have 15 minutes. So if you have any questions that you think might be sort of generally applicable, I'm hesitant to try to give a patient-specific reaction. So I'm happy to do any in the 15 minutes. I would just say, in general, for families, if I can't figure out the why to your sudden cardiac arrest, I don't think we have any choice but to maintain the defibrillator protection plan. If we haven't figured out the name or identified a reversible cause or figured out the new name, so for example, you mentioned you're on 5 defibrillators. So a CPVT person who does cardiac arrest as their portal of entry in 2022 doesn't have to get the defibrillator necessarily. That's completely different than what it was 5 years ago, 10 years ago, 2 years ago. So, but if we're stuck in a dilemma of we have essentially inadequately explained or unexplained cardiac arrest, we really must keep a defibrillator strategy present, and to willy-nilly remove it because we've had 8 years where nothing has happened, which is great during the life of that, that's not sufficient proof yet that that episode was a one and done, and therefore we don't need it again. So I think we have to be careful when we don't know the why. Yeah. Jeff, you.
No, yeah, I would agree with that. I think, like Dr. Ackerman is alluding to in some of these, I think it needs continued reassessment, and sometimes things change. Our knowledge base changes very quickly, and just because you had a device placed doesn't mean 10 years down the line that knowledge base and the assessment is the same. And if you don't get that reassessment continually, then I'd advocate for you to springboard that discussion. I have some families where there's 6, 7 kids that have a diagnosis, and the way the oldest was treated and the youngest is very different. The oldest might have an ICD because that's what we were doing back then, and then the youngest doesn't. And it's confusing for the parents to say, my kids have the same thing, how come they're not treated exactly the same? So I do think as knowledge changes, it's continual reassessment of what's needed at the time based on the specific diagnosis, the specific patient, those kinds of things.
Thank you, everybody. Dr. Ackerman, you started talking about reality check on the arrival of gene therapy, but you didn't. I think you were going to say some other things, if you wouldn't mind, before you leave.
Sure, yeah. So gene therapy, as you heard from Dr. Landstrom, is super exciting. But in every new novel therapeutic pursuit, I think super excitement needs to be calibrated with the reality of the pace from a discovery paper to a pre-human animal model that it's working to a first-in-human filing to testing that gene therapy to seeing if it works. So let's say, I'll give a couple examples. So it's already here, as in, has it started? There's a disease, you wouldn't have any reason to know it. It's called Danon. It's a specific genetic form of a heart muscle problem. The first patients in New Zealand have been injected with the gene therapy for that defective protein LAMP2 or that gene LAMP2. So it has begun in our field. The next in line is a gene therapy from a company called Tenaya Therapeutics, who's one of the sponsors of this meeting. That's a specific gene for one of the 2 most common causes of hypertrophic cardiomyopathy, which I don't think anybody has that heart muscle condition in this room. That disease, that therapy first in-person trial will likely start, best guess, 6 to 12 months. Probably pushing it closer to the 12 than the 6, okay? So then there's in the queue, I don't know if any families have ARVC, one of the 2 most common genetic causes of ARVC. That's in the pipeline. That's probably 2 years from commencement. The one that Andrew Landstrom showed you for long QT syndrome that we were advancing, which is being co-developed by Pfizer, is being injected into the long QT rabbits as we speak. So if it works in the rabbits, we file a first-in-human trial, which would start probably 12 to 24 months from now. If it doesn't work in the rabbits, it's game, set, and match, and we start over. Okay, so things get clarified in a hurry with these. Let's say any of these gene therapies work from the first injection into the human. So if you read that the first patient was treated the fastest and everything's working, the fastest you are going to see gene therapy for that specific disease, for that specific gene therapy, I would bet is minimum 5 years from now. So to get through all of the regulatory hurdles, to convince ourselves in what's called a phase 2 trial that there's a signal of safety, phase 3 trial that it actually works and so forth, and then we do it, this is not, we publish the paper, we're going to tell you it's exciting and it's here, and we start treating our patients with this therapy summer 23. It's going to be summer 2030. Okay? And that's if we have success. Now, the good news is there was never any of what I just said discussed at our last SADS meeting pre-COVID. We didn't even have the chance to give you a potential date of success. We didn't have to tell you that Tenaya Therapeutics is advancing a gene therapy. Pfizer is advancing a gene therapy. Another company, a gene therapy. The space of companies who are now committing serious energy and money to your diseases is like it's never been in my entire career. So that's exciting because that's going to incubate. What we're doing may not work, but we're going to learn something that will work. And the collective knowledge that's advancing with gene therapy to figure out how do we safely do it so that the person doesn't react in a negative way to the viral vector. What's really been exciting about the companies, so the companies, they're competing mano on their target. What they're not competing on is the safe delivery. They're all sharing best practices on the safety signal. And they're talking to each other and they're saying, what should be the pre-infusion treatment so that the immune system doesn't react? And so that's what's been really kind of neat to see, is in that world, and you know the why. Why would they be cooperating on the safety signal? Because if there's some deaths from safety, the whole gene therapy program of every disease could potentially get killed. So they are beautifully cooperating and partnering with that space. Now, if they own the rights to that gene target, well, then they're the lead dog for that specific gene, for that specific disease, but not on the safety signal. So hopefully that gives you a sense of maybe a sort of realistic time frame. But gene therapy is not the only thing. There's going to be a first-in-human drug trial for the first new drug for long QT syndrome, starting in LQT3 and LQT2. And that new trial will probably start enrollment. I'm guessing we'll start first patient enrollment summer 2023. There, the track could be a little faster because you can imagine the regulatory hurdles aren't as intense. So if that drug works and it's safe, we could have a first new drug where the indication is long QT syndrome, right? Which we don't have. We don't have a single drug that's an FDA-approved drug for the indication long QT syndrome yet in the history of this disease. That could actually be here confidently summer 25. So that's pretty exciting, I think. Yeah.
I think I overheard you mentioning something about maybe not keeping patients that are asymptomatic on beta blockers for the rest of their lives. Could you touch on that?
Yeah, and I'd love to hear their comments too, because we, I don't surf, but I'm always told that if you surf, you don't want to get caught in the bad part of the wave, because sometimes leading the wave, you can get crushed. So we have to be pretty careful with this strategy that we've started in our program. We call it INT, intentional non-therapy, where we know you own the genetic marker. We know you have disease, whatever, but we've concluded to our satisfaction that we think all we need are the preventative measures. Drugs to avoid, electrolytes to replace, fever to reduce, and we may not need every day of your life therapy. So we started doing that. And we have now in our program over 100 patients where I know I'm not wrestling with the diagnosis like this challenge that Dr. Miyake has with your family. I know what the diagnosis is, but we're saying, I think we don't need treatment. Now, you can imagine the families who are helping blaze that trail. Those are largely families who've said, I think we've traded a low-risk disease for, you've changed my child with this medicine. Again, I don't want the word to leave here saying beta blockers are terrible. They're not. They work great in many people. But the self-declared people where it doesn't, they're the ones willing to say, is there potentially room to navigate non-treatment? So we have many babies who we think the profile is low risk, that we're actually not starting them on their medicine, and we're watching. We are now tempting ourselves with, say, the LQT1 man, who maybe the beta blocker was necessary for his first 15 years of life, but is it going to be necessary for his next 75 years of life when we know the risk window changes? And that's going to be really hard for us to do. Because how do you know that they navigated that first 15 years great because the medicine prevented the events, versus they would have navigated that first 15 years of a higher risk window just fine with no medicine? So I think we're all going to have to be very, very careful on this, because I think none of us want to get snake bit where, the guidelines currently say, if you own a positive genetic test, thou shalt be on medicine. That's the guidelines, basically. There's wiggle room of a class 2, meaning sort of maybe possible for if your profile is super low. And we've taken that as the lead to say, if not now, when? And we have to start that for some families, for the right patient, the right therapy may be no therapy. So we're being careful, and I imagine, I'd be curious, Ron, your thoughts, Christina, Jeff's, as somebody who may not have the volume of patients to say, we'll blaze that trail, versus wanting to watch how that story plays out, because we all know that we're over-treating some patients. So it's an interest. Withdrawing therapy or choosing not to start therapy is actually intensely difficult viscerally for us as caregivers. But I think it is the right thing to do in certain patients. But
I think it becomes increasingly difficult as the patient ages and remains symptom-free, and like any other medical condition.
Thank you. The longer you feel well, the more the disease, the diagnosis is in your rearview mirror. And you have to be reminded, especially in long QT syndrome, that whereas the day-to-day life events don't pose significant risk to you, the kinds of medications that we tend to require as we get older because of age-acquired medical conditions will tip us over the edge in terms of potentially going into a dangerous rhythm. So it's a very complicated process. And I'm not talking about the 15-year-old that Mike is talking about. I'm talking about the 40, 50, and 60-year-old. And so being careful is important, but also not losing sight of the condition that you will always have in terms of the genetic abnormality and the potential that it provides. Whereas the hormonal changes that occur in early life play a major role in risk, and those conditions change as our body changes hormonally. We introduce new cofactors or elements as we get older, and we may go into heart failure and have to be on diuretics, which affect our potassium, or we may have certain infections which require medications that can destabilize our potassium channels. So it's complicated.
Mm-hmm. For me, I think that you really want from your physician to always look at what's going on with the research, what's new information, and particularly in genetics, to keep up with the genetics. So in other words, even if you're a known disease or a known mutation or an unknown, or you're an unknown cardiac arrest, your physician, or, at least it's my practice, to question it every time you come in. What is the diagnosis? Do you need to absolutely be on this medication? Are we on the right medication? And for me, what I've learned is, honestly, in the field of long QT, and I think this is important, is you see us kind of referring to each other, well, this is kind of your lane, and this is, and yet we all work together, right? We're all sitting here training and trying to share information about certain areas where we might have a little more expertise or a lot more expertise. And I'm pointing out Dr. Ackerman because if you don't know, he is the person in long QT. And, and so if you guys know me, you'll see I have no problem referring you to Dr. Ackerman. Many of you have gone to him. I have no problem with you seeing other experts, but we also learn from them. And so I think it's from what you are putting out in the literature in terms of not only sports, but in who should not be on medications, who might not need it. Here are some guys. I think it's coming from him. And I think when you hear my other families, why am I actually taking you off the medications? It's because I'm listening and I'm paying attention to the literature and what Dr. Ackerman is saying, and then really analyzing, do you really need this? And it's not easy. This process took us, years, right? Several years to make sure we were doing the right thing and reassessing and reanalyzing and make sure this is the right thing for your family. So actually, Mike, I think I listen and I follow your guidance a lot, in terms of what and these sessions, we learn a ton from each other from this. So I think we take it back to you and we take it back to our clinics, and none of us is an expert in every single thing we're always learning. That's where I think. But it's hard.
Yeah, I don't have a ton to add to that, but it is an incredibly hard decision for us if you want to hear our perspective. It's hard to decide when to start a medicine or when to put in a defibrillator. It is harder for us to decide when to stop a medicine and take one out when we have patients that have been doing well. So your voice matters, because the things for me that influence that are your reasoning, and how people are doing. If someone is having a really hard time with the medicine, that plays an important role in whether or not it's something we could come off of, and things like that. But it's a hard decision for us.
I have one that I hope is simple. So other than attending these seminars, is there like a place or something we could follow, like maybe the SADS website, or is there a newsletter where we could get the latest news and find out, did the rapid gene therapy work? Are you guys back in the drawing board? Is there some way that we could figure that out as lay people? And with the medical societies, I'm sure you guys are reading your journals and things like that.
SADS Foundation is your home.
Yep.
Okay.
So if it's not there on www.sads.org, tell the SADS team. If we're missing things that are your need points, that's what we at SADS Foundation need to know, because we want SADS Foundation to be your one-stop resource for your family support needs, your advocacy needs, for keeping you updated. So we don't have enough money at SADS Foundation to fund $100,000 project requests. So we've chosen as an organization that that's not where our giftedness is, or where we can meet families' needs the best. What we are there for is, you need support, it's SADS Foundation. You need advocacy, it should be SADS Foundation. You need to know what's the state of research, or what trials have started, or where is there a place that's offering enrollment. It should be the SADS Foundation, and you should be finding that. If there's specific requests that you have, let Alice and Marcia and Anna back there and Jan back there know.
We also have a weekly, twice a month, e-newsletter that you will all receive unless you tell us you don't want that by signing up here.
Great to see you guys. Thanks for everything. Thank you. Well, Bailey and Madison's mom joined because Namdi is saying I'm on the clock. That's the Toyota guy who says, did you know that if you're 2 minutes late after the assigned time, it's 2 minutes. So anyway, have a wonderful, wonderful rest of your program. Blessings to you. Thank you.
No, thanks. Travel safe. We do have a few more minutes if there's other questions or things. Yes.
All right. So my question's on the beta blocker and flecainide. Is there still new medications coming out, maybe? Like research done for less side effects? And my daughter's on both right now, and she's a cardiac arrest survivor and has had shocks by her defibrillator. So she's doing well with the medicine, but we're noticing mood swings, anxiety, and stuff getting worse.
And is this for CPVT?
Yes, I'm sorry, yes.
You want to go?
I would say that right now, those are the two main medications. So those are your mainstays right now. I do think that sometimes we may dose adjust because we really do want to pay attention to those side effects. However, right now, those are the ones we know are the most effective. There are, and you'll see, I'm actually going to talk about some new medications or new drugs that are being investigated right now for CPVT, but they are not yet on the market. They're actually just going through and just starting the clinical trials. So in terms of medication, those are the two. And you heard us talk a little bit about the alternative therapy, which is the sympathectomy.
That's what's next on our stack. She keeps.
Yeah. A sympathectomy is something that's used quite a bit for CPVT. And in scenarios where we have patients that are really intolerant of medicines, that's one of the reasons where we do talk about getting that done, because it has been in people effective in reducing the risk. Again, it doesn't really eliminate the risk and doesn't always mean that you get off medicines altogether, but it does help with reducing that risk. Any other questions?
I've been sitting on this because I'm not exactly sure what my question is. I think I need some guidance on where to go next or what next steps are. When Dr. Ackerman said something about, after you have an event, you get your ICD installed, a lot of providers, it's like, okay, we're done, that's taken care of and there's no more detective work. And I'm new to this. I just had an episode and I experienced VFib in August, got a defibrillator immediately. And we sort of have a why. I have a prolapsed mitral valve, scarring on my papillary muscle. And so they think the scarring is what did it. But my question is, why now? Like, why did it happen on August 22nd? And were there environmental factors that played a role? I had been on 3 different antibiotics for a sinus infection, and so I have questions. I want to start digging, but this involves a lot of different specialties and doctors. And so what do I do to work with my brand new EP? And I haven't even met my cardiologist yet because I transferred from the hospital I was at to Houston. So anyway, any advice or like how to navigate this? That's kind of where I am right now.
Yeah, I think as you heard, I would advocate for you to find that partner champion to centralize advocacy for you. And SADS is very helpful for that. If you wanted to engage after, if you're local, I think it's something we'd love to do. And sometimes it's hard to find the right fit for that. Mm-hmm. But I would advocate to keep searching if you don't feel comfortable. It sounds like maybe your diagnosis is something called mitral annular dysplasia or disjunction.
They just say arrhythmogenic or malignant mitral valve prolapse.
Yes.
Is what they've been.
Yes,
so.
and that's something that's newer and that you see a little bit later in life. And the question you ask is a very hard one that I think almost everyone here would have asked themselves is why did it happen on that date or when? And the reality is sometimes that date's not predictable, especially if you don't have that diagnosis. Mm-hmm. If we have screened the family and we know a diagnosis before something happens, it's a little bit of a different story. But it's not uncommon that you're very healthy for your childhood. A lot of the diseases we see don't come out till young adulthood. Mm-hmm. and that's when it presents. And so I don't have a great answer for why it happened on a specific date or things like that. For mitral annular disjunction and mitral valve prolapse, there is a lot of looking into and work that's going on. And so certain medicines, including flecainide, which has been used with that quite a bit, as well as some places where they've done other things in terms of looking at the papillary muscle. But I would advocate, if you don't feel comfortable, that you're getting that centralized advocacy for you to keep searching.
Yeah. As a peer, I would like to help you with that. I got a big mouth. It's big. As a peer, I would love to help you with that because I am a patient at Vital Heart and Vein. They may have a place close to here, but I'm in Humboldt, Texas. And the cardiologists are very into SADS and they're very knowledgeable, and I would consider them experts. That's a good place that you could start. I'm not a doctor. But they have been extremely pivotal in helping people like us because I experienced my first event when I was 30 years old as well. So you could start there.
And I think that it's good that you at least have some. At least they've given you some information. I think I'd probably be a little more specific because there is mitral valve prolapse, the malignant form. There's mitral annular disjunction. And you also want to make sure, is that definitively your diagnosis? Could it be something else? And it is common. It is much more common in females, this MAD, and particularly young females. I don't know your age, but in general, starting in their young 20s, much more. It's just we know that that's a common age. But at the same time, when you talk to your physician, I think you get that. Hopefully you get that feeling, is my physician listening to me? Are they, when I bring up, was it antibiotics or was it this, are they listening and saying, okay, I'm hearing you? Because personally, I think that we learn a lot. I learn the most from you guys. And maybe there was something about that antibiotics, but no one knows. And I'm not saying that they're always going to pay attention because sometimes there isn't a connection and we know that. But you want to make that connection with your physician and make sure they're hearing you and you feel comfortable with your diagnosis. I don't think you should ever leave and live for years without knowing your diagnosis. And I know there are people in here who didn't find their diagnosis for much longer, and maybe because they didn't have that, their physician wasn't always asking, and that's what you want. So if that's not, and that's what I think he was saying, is making sure you have that. SADS is definitely the right place. But you have, what's wonderful about this is you're meeting others that are going through the same thing. And hopefully if you continue to connect with people like that, you can find different avenues until you find that right. Don't feel like you have to stay at one spot. Look around, use resources, and find the right person for you. And it might be where you are. It's just,
Other questions? Okay. I thought we were going to spend half the time talking about sports and participation, which is where it usually heads, but it didn't come up.
Since you want to go there. My oldest daughter is 15, and she actually came here. She sees Dr. Valdez.
Okay.
And he's incredible. It's me. I'm the problem as far as her athletics. It's the parent. She wants to play basketball. She wants to run track. She wants to play volleyball. She does all of these things. But she's also very intelligent. She's in tune with her body. It's me. I want to be able to tell her, yes, go do those things. They're amazing. And go run your heart out, but not literally. And she's on treatment medication daily, almost the same dosage that I take as well. As a parent, with your experience as a pediatrician, what are some things that you would be able to offer other than support groups? Maybe, I don't know what I'm asking, but what have you seen in other parents that are like me, and maybe some people in the room who freak out and make sure that there's an AD on the court and things like that?
Yeah.
Because I also have long QT, and that triggers my anxiety. So there's that.
Yes, no, it's a great question. And I think what can we offer, what I would say is probably data, because what we all hate is the ambiguity around it. And the reality is that we're never going to be able to tell people, even without any of these diagnoses, that your risk of doing something is 0. But what a 0.1 or 0.2 or 1% risk means to you may be different than what it means to somebody else, maybe different than what it means to your daughter. But you can't even get to that point if you don't have the data. And so I think one thing we could provide is to go over that data with you. I would say that the model for this is now, and you've heard the term shared decision making. It's new. It's not long ago that it was you have a diagnosis, and it was easy for us back then, to be honest. You have a diagnosis, you can't do X, Y, Z. But really, for long QT and a lot of these other diagnoses, it's about shared decision making. And that word shared is important. And it's something that I still haven't taught my youngest daughter. I don't think she understands what shared means. But shared means that it's bi-directional. And so with a child, sometimes it's 3 people. The child, the patient, the parent, and the physician. And if you have one party that's not involved, then that's a problem. And if you have a physician that says this is how we have to do it and doesn't listen to your side of it, that's a problem. At the same time, I think if we have a patient or a family that comes in and doesn't want to hear anything and says this is what I want to do, I think it's also a problem. So I think it's a long, important discussion and a shared decision that you make. What I would say is that most of these diseases now we've shown that the risk of having an event during sports participation is low. If you're followed, you're treated, and you're managed and having these discussions. Not 0, but low. And there's some diagnoses that are a little bit different, so it depends a little bit on the diagnosis. But I think having that shared decision making to do that is important. Your perspective is important, and I think your daughter's perspective is important. In the era where we restricted everybody, one thing we saw very common is that the child or the patient got very depressed. Their life was shattered. It was very important. That's an important part of the balance, because when you hear the statistics and the data and you say, well, maybe there's 1%, and you see the impact that the restriction had on your child, that could shift it. And I've been on the end where I've restricted too many patients, and I see how they've changed. And that's what's really resulted in that model, is that you have to factor all these things to make sure that people are still able to engage life, which is the whole purpose of SADS. Whole purpose of all this is that we want people to continue to engage life in the things they want to do.
I was just, do you want to?
I'm over here. Hi. I was just wondering, having gone through this for the majority of my life, and then when I had to be 12 years old and I was put on this beta blockers, it changed my life. Like I could actually be active and do all this other kind of stuff, but it made me feel, I didn't know it would make me feel slower, because of just the beta blocker, which I was fine with as long as I could play football and all that kind of stuff. But from an emotional, like you just meant from an emotional state of mind for the child, how do you go about explaining to him that things it'll change or slow down? You might feel this, or is that obviously that's very tough for you.
Yeah, I think my approach to, particularly, it's a little bit different if you're a child. I do think it's important that they're involved and understand something, to not hide the diagnosis from them, but you might want to talk to them differently. But once they become a teenager and the 12-year-olds, I really think they should know what's going on. And so I'm very open, and I tell my patients, we need to have a very open relationship here. You need to tell me what you're feeling. We need to be able to talk. And so I think that hopefully, you're kind of a survivor. It's been a long time, but hopefully us physicians now are learning from you and talking to you and telling you, here's your diagnosis. Here are your medications. And I make my patients tell me their medications, their doses. be responsible for your own health, and here's how you might feel. And if you are, then tell me so we can work through that. So I do think that's an important part. Work with your physician in terms of your questions. Absolutely, it's important to recognize that these diseases, they play a toll on your psychological health too. And so it's really important that you also consider outside counseling or someone else to support you and your child to go through this. And be open with your physician. You know, sometimes we don't always do this, but we probably should. Be willing to maybe step out and let your teenager talk to their physician, tell them openly what they're feeling, and encourage them to do that. And then also encourage them if they, you know, I encourage everybody, regardless, to have some counseling, because this is difficult. And there are some counselors, this is really hard to find, but Sam Sears was here yesterday, and he focuses on cardiac diseases, devices in children. And actually he trained the psychologist here who know more about these diseases and the manifestations and repercussions that it can have. So I think, you know, working with your physicians and being cognizant of what it can, you know, what it can mean for your child, and at least you recognize it. I think that's really important.
Mm-hmm. And I would just say, don't let us tell you that we're only caring about this.
Yeah.
This is what we trained in for years. But if your physician says, I don't care about anything else other than your heart, then that's not right. Because we know that, you know, people are much more than just their heart. That's what we're focused on. But it's coming much more into focus that everything interplays. We need to pay attention to things like that you brought up.
One thing that's given me peace of this, is this louder than it was earlier? Okay. Given us more peace of mind as parents, our daughter is 9 years old and she has CPVT. She's diagnosed right before she was 6 years old. So it's been almost 4 years, and we've been with Dr. Miyake the entire time. So it's been a journey, and she has a loop recorder, which for me was a decision we made with Dr. Miyake and with ourselves and with her to make us feel better about allowing her to do more things, making sure she's medically managed correctly. And then that was the other piece of the puzzle and I explained to her that this is something that will help us hopefully enable you to continue to be an active child. And she understands why she has it. And she understands doing a transmission that gives information to Houston that, you know, makes sure that things are okay. And as long as they are, we can continue to lead a more active life. But that's just something from our experience that I wanted to share, because it helps me feel a little bit better about giving her that blessing to participate in things like that.
I'd just like to say a PS to what I said before. But I am so thrilled to be here and hear of all the advancements that have been made to what I once knew was a helpless situation. I was in the wilderness back in 1973 when my child, my 3-year-old, couldn't run or ride a bike or anything without quote fainting, and I had nobody to turn to. Nobody. We had the best pediatricians, neurologists, neighbors, everybody who wanted to pitch in what they thought. And that went on from the time he was 3 years old till 10 years old, and he passed out 35 times. Riding a bike, jumping on the bed, dancing in a group. And so when we finally heard by not a mistake, a quirk from heaven, really. I was at a luncheon, and some ladies and I were talking, and we got to kids, and I told them about this child of mine fainting, and this one lady said, has anybody ever mentioned to you QT? Now that's how it saved his life, because I had a tour business at the time. She wrote me a thank you note and she said, if you've never heard of this QT, go see this doctor. And my pediatricians, neurologists, and everything, the best in New Orleans, said, he's over the hill. I don't want to pay any attention. And so we did. And the best he did was tell us he was on his way to Rome to study this prolonged QT thing. He had never heard much about it either. And when he came back, he told us to be there with a chest x-ray and a new cardiogram. And he walked into the office that day and he pitched a brochure on the desk towards my husband. And he says, this is what he has. It's fatal. And that's it. I said, is there anything, nothing they could do? And they said, oh yeah, cut something in his neck that would paralyze his face and close his eye. And so I was frozen in the office. And when we left, I said to my husband, a very stable, good guy, a lawyer, and I said, well, what are we going to do? He says, we're going to lunch. He's nuts. But he really wasn't nuts because all the neurologists and pediatrician had said if he went 18 months without fainting, it was probably idiopathic. Well, he bombed out 2 months later, and then I gathered all of his records from all of the doctors, and we went to the LSU School of Medicine. That doctor concurred with the one who was nuts, as supposedly to seek. But and this is a really soap opera because he discovers what the other doctor said was true, but nobody ever heard of this QT thing. And so we go the whole summer with nothing. You know, nobody said anything. And so I called the pediatrician in late August, and she said, did you ever get the prescription? How is Matt doing on the prescription from Dr. So-and-so? I said, I don't have a prescription. And she said, what? And I said, I don't have a prescription. Very first woman doctor in New Orleans. She banged the phone down. She said, I'll call you back. Then she told me to race to this cardiologist, pediatric. And let me tell you, he didn't know about it either because I tried to explain to him how all those years of his passing out, we tried to keep a good sense and saying it was a tonic. It was a tonic and it made you feel better and all. And he bought it. But this time it was when he said it was fatal, we had to do something big time. So that pediatric cardiologist treated him till he was in college. And he certainly learned about the QT. So after this long dissertation, I just want you to know how lucky you are to even ever heard of that and all of the progress that has been made for you to be able to breathe a calm breath and not have to be in a quiet panic for the rest of your life. So thank you, doctors, and thank all of you for letting me rattle on. Okay, that's it.
Thank you. We love those sessions. Maybe we'll give everyone just a few minutes to stretch legs. Push forward with the agenda. Yeah. Oh, yeah.
Thank you. Do you want me to go? I can introduce myself. I'm thinking that's fine.
Hi, everyone. My name's Lindsay Myers. I am a genetic counselor by training. I have been a cardiac genetic counselor since I graduated school, so a little over 10 years. And I'm going to be talking a little bit about what a genetic counselor is and does in genetic testing. I recognize that a lot of you may have already met with a genetic counselor or had genetic testing. So it would be interesting to me if you've met with a genetic counselor before. Could you raise your hand just so I kind of get a pulse? Awesome. Some of you have. So this may be a refresher or review for some of you, but also I would challenge you to look at in light of how I talk to my family members, or if you have children, when they get older, they may see a genetic counselor when they're thinking about having kids or going through that transition to adulthood to rediscuss if they've had genetic testing or their diagnosis in general as far as family planning implications too. And if you have any questions, I'm happy to stop. I've kept this very basic, so if you have any more questions you want me to dig into, I'm happy to go into further detail. So first, I'm going to start off by the basics. Who are genetic counselors, and really what is genetic counseling? Our training is in medical genetics and counseling. We have master's degrees, usually in genetic counseling or sometimes human genetics. So we're not physicians, but we are a medical provider. And because we get training in both genetics and counseling, that equips us to not only talk to the genetics of particular conditions and how that could affect you and your family, but also recognize and give some guidance on the emotional impact of these. So a lot of feelings can go along with thinking about our family, grief, worry, all of that. So they can help talk through some of those as well. And we work as part of the healthcare team. So we usually will work with your physicians, cardiologists, or other physicians that may be involved to help them say, what is this genetic testing or the family history? How does that maybe impact your medical management or your child's medical management? Is there anything else we should be thinking of with this particular result? And what does this result mean? So we work kind of all together with the healthcare team. Okay, and then I have the actual definition of what genetic counseling is up there, but I think the take home here is it's a process. So we can talk about, as I mentioned, the medical implications, but also the psychological implications of a genetic diagnosis with or without genetic testing. I know a lot of people think genetic counseling equals genetic testing, but I want to erase that conception because we would rather just inform you and give you the details, and it doesn't equal genetic testing always. So I know that can sometimes get put with genetic counselor. So the genetic counseling model, just a little bit more about it, it really is an active process. So they had mentioned shared decision making previous, and that has always been our motto. We really want to have an active conversation with the families and answer your questions, get any concerns, your prior beliefs, your values, whatever that is for your family, and take that in consideration in our conversations. So that kind of leans to the patient-centeredness of it, and that we are also non-directive. So we may make recommendations or give some screening guidelines, but we do this so that you have all the information, and we're not meaning to say this is what you have to do. And then that is because we want to empower you to make the decisions that are best for you and your family. And then I already spoke to this a little bit about the anticipatory guidance. So we can cover sometimes like how people may feel after they have a genetic test, or how people may feel talking to their child about a diagnosis or their other family members, and give you some tools to help with that as well. So a little bit more about what we do and actually what's in a session. So one of our main goals is to educate. We talk about what are genetics, what are the genetic implications of a particular condition, and we may even talk about non-genetic contributions to a particular condition. So if you take acquired long QT syndrome, we may ask, are you on medications that could prolong the QT interval, and try and take that into our risk assessment. We'll educate on how this may impact the rest of the family, how a condition may be passed down in the family, and then also about genetic testing options if those are available. And then on the back end of that, if somebody does have genetic testing, we really can help to interpret those results. If you get this report and you're like, I have no idea what this means, there's a CDOT and a PDOT, and this is really just foreign to me, we are the people that can also help break that down and explain, okay, this is exactly what this means, and here's how we may use that for your medical care or your family's medical care. And I think one of the biggest things is we really want to serve as a support to families as well. I mentioned earlier, if you need support talking to your extended family, if you need, some people don't know about SADS, so we would definitely hook people up with SADS and other support organizations. Sometimes we connect families together that are going through a family that's going through a particular situation that's looking to connect to another family that's been through that for support. So we can offer all of those resources as well. And then at the end, just, this probably should have been moved up, but assess. So if you've ever seen a genetic counselor and they're asking you all these very personal questions about your family history, it's really because that goes into our assessment for your genetic risk for a particular condition. And I have a little bit more on that later, but it can help us pinpoint who else should we be talking to? Who else may be at risk and need genetic testing in your family? So that's kind of the process of genetic counseling as well. I like to put this slide up there, what we don't do, because there can also be some misconceptions about that. We are a genetic counselor, but we are not a therapist. We're not psychologists. We do not practice as a licensed therapist at all. It's really counseling about how a genetic condition may impact your family, and then we can also recognize, or we usually recommend, as they previously did, I think it's always helpful for families to go to a therapist to talk to other things for psychological impact of some diseases. We do not require genetic testing. If you're coming to a genetic counselor, we are not going to make you get genetic testing. We may talk about it with you and discuss that with you and what the pros and cons are, which I have some later, but we do not require that. So, and then lastly, we don't recommend that you don't have children. So a lot of people also think of genetic counselors as like, they're going to tell me I'm going to pass this down and I shouldn't have kids. Absolutely not. We want you to understand your risks, and if there are other options out there that are available, we want you to understand that. But it's your family and your values, and every family has different experiences with things that impact their decisions for family planning or whatever else it is. So really, our job is to make sure you have the information to make the best decision for yourself. So just a slide about if you are seeing a genetic counselor, what can you do beforehand? It can be helpful to gather your family health history. I have some questions on the side that are specific to inherited arrhythmias that we may ask some details about. So you can read through those, but that is because most of those questions can help us with the risk assessment. And is there something in the family that other people have that they didn't really know? So like sudden unexplained deaths, this would include people that had a single motor vehicle accident. So they were the only one in the car and they had an accident where they crashed into a tree or something, or drownings as well. So we may ask some of those questions. So sometimes it can be helpful to reach out to your family members, because I know I wouldn't know that off the top of my head, and I'm a genetic counselor. So we don't always talk about those things at family gatherings. So collecting that information can be helpful. So during the session, we can take a full family history for that. And then bring any questions or concerns that you may have, whether it's about genetic testing, if you read something online about the condition, or the genetic contribution or other risks, we can also help address those. And sometimes it's helpful to consider bringing a support person, whether that's a friend, a family member, whoever, because it's a lot of information. Genetics sometimes isn't the most exciting. I'm biased. I might think it is. So it can be helpful to have somebody to help you remember some of those, especially if you're just already getting a lot of information. If you're meeting with a cardiologist the same day and then a genetic counselor, it can be helpful just to have a support person in general. So during the genetic counseling visit, what will happen, mainly you'll start off by contracting. And really what that is in genetic counselor terms, it's goal setting. So why are you here to see us? And what do you hope to get out of today's visit? So we really want to know what you would like to discuss, what you've been told prior. And we really will assess that because we want to make sure that we're on the same page and we can discuss in context of other information you may have been told. We'll go through your medical history. So if we have access to your medical records, we will have assessed that and already taken it. A lot of times genetic counselors work within a cardiologist office, not always. Sometimes you go to them in another office. So that can, if you're seeing a genetic counselor outside of your cardiologist, it can be helpful to bring your records or have those sent so that they know that ahead of time, especially if you've had genetic testing prior. Those are really important to send over. As part of the medical history, that includes your family history. So that's where we'll ask you all those questions. We'll draw out a pedigree. Have you guys had a pedigree drawn out for you before? Most of you? Yes. I have a picture on the next slide. And the pedigree is basically our lingo for our family history. And that can really help us in that risk assessment and kind of help decide who should be tested, who might want to talk to a genetic counselor, who might you want to talk to within the family to discuss these risks. And then provide guidance. So once we've given you all the information, we can really sit down and talk about how you would like to proceed. So this is an example of a pedigree or a family history and how we draw them out. If you've seen it before, you're probably familiar with this, but really squares are the boys and circles are girls. We have other symbols for non-binary people and other genders. We also have symbols for if you're adopted or if somebody is adopted in or out. So this is just showing the basic ones. And really it's just constructed from generation to generation. So the bottom is one generation. So this would be somebody's, this person here would be our proband, which is just the first patient that comes in to see us, brings to attention. And this would be their children, their brothers and sisters, and their niece and nephew, and so on. So you can see that labeled out. So that when we're scribbling down all those squares and circles, that's what we're doing. And it's really to help us with the risk assessment. And your cardiologist can be helpful as well. So, to wrap up the genetic counseling section, really our goal is to support you. So as a genetic counselor, what I want you to take home is that you feel like you got the information you needed, you feel like you got your questions answered, and you feel like you kind of understand what outcomes may be if you decide to go with testing or without testing, what the possible results are, what those implications could be for you and your family. And then I'll transition and talk a little bit more about genetic testing as well. Questions so far? No. Okay. So moving on to genetic testing. I'm not going too depth into the different genetic tests for the inherited arrhythmias. I'm just giving kind of an overview. So one, genetic testing is pretty universally recommended for most inherited arrhythmias by all of the major medical societies. So you've probably heard of maybe the American Heart Association would be an example of that. They all come out with these guidelines on how we should take care of our patients. And for genetics, most inherited arrhythmias have these recommendations that patients with a diagnosis should be tested. So anyone who has a clinical diagnosis of a particular inherited arrhythmia, they recommend testing for. And then if somebody in the family has had testing and they were positive, they also recommend testing for at-risk family members. So what that means is it's typically covered by insurance, because once something is a medical guideline, insurances then will start to cover it. So genetic testing is typically covered by health insurance. It is so much cheaper than it used to be when I first started. It was like $5,000, I think, when I first started practicing, and now self-pay prices around $250. And not to mention, a lot of labs have other financial assistance programs, so they will discount that based on your income. Some people that are uninsured or have Medicaid, also there will be no charge associated with some labs. And genetic counselors, we can help find those things. We can help find the most affordable way to get that done, because we really don't want cost to hinder your access to genetic testing. And when we do genetic testing, I mean, there probably are a little more than 3, but universally we think there are 3 possible genetic testing results. And I only say that because we typically just think of positive and negative, right? Positive, great, we've confirmed the diagnosis, we can talk about it. Negative has its own implications, which I'll talk about. But there is this other option or other result that you may hear, variant of uncertain significance or inconclusive. They are the bane of all of our existence, but they are very common. I have a slide on that. So really, that means we found something, but don't really know what it means. So it can add a level of uncertainty, and I'll talk more about that as well. So some benefits and limitations to genetic testing. Benefits, it can help confirm a clinical diagnosis, especially if there's some question or unsure. We don't know if maybe this is acquired long QT or congenital, for example. Or we think somebody's EKG pattern is consistent with CPVT, but this can really help confirm that diagnosis. And sometimes it can help guide your medical management. So for long QT syndrome, sometimes the underlying gene that's identified, we can then say, okay, we know for sure you have long QT type 2, and then we can know the triggers that go along with that a little bit better. So for type 2, we know that postpartum women can be a little bit higher risk, so we'll counsel about that, and the cardiologist then can use that information to also help manage those patients. And sometimes a genetic test may say, okay, your heart's affected, but maybe we need to worry about something else. This is rare in the inherited arrhythmias, but it can happen. There may be other heart rhythm issues that go along with that we weren't thinking about. Sometimes heart muscle issues can go along with something that we weren't thinking about. So they can sometimes impact your medical management for sure. Importantly, it also helps inform your family's risk. We can tell you what your risks are to the rest of the family members, and it allows for them to have genetic testing so that they then can say, yes, I have this, I'm at risk, I need to be followed, or no, I don't, I'm not at risk, my kids aren't at risk, and I don't need to be followed. And then something that exciting is coming more up are access to research and clinical trial opportunities. A lot of clinical trials may say you have to have like CPVT, but it needs to be genetically confirmed. So sometimes having that genetic diagnosis allows you access to those clinical trials. Conversely, if your genetic testing is negative, that may open up research opportunities to try and identify the underlying genetic cause in your family. So that can help. Some limitations. We don't know everything. We're still learning. So no test is perfect. For long QT, about 75 to 80% of the time, we can identify the underlying genetic cause. CPVT is a little less, so it's about 50 to 60% of the time we can identify it, and Brugada syndrome is even lower, so about 25% of the time we can identify it. Which is important because what that means is a negative doesn't take away your clinical diagnosis. So if you've been clinically diagnosed with Brugada syndrome and your genetic test was negative, that doesn't negate what's been given to you clinically. And then those VUS or uncertain results that we talked about can really be anxiety provoking for some people. I think was something we could talk about in genetic testing, but people may know how they deal with uncertainty. And sometimes if people are really, really anxious, we'll talk through that and or we always talk about it with families, but just kind of knowing how you may react to that based on how you've dealt with uncertainty in the past can be helpful. Okay, that's all I wanted to say there. Questions about any of this so far? I wanted to give a couple. Oh, yes, go ahead.
Doesn't it change the more data you get? And how does that, so if you've been diagnosed, you've got that mutation, how do you know, how it's changed?
How it's changed? It's a good question. So I have, I'll answer. I have a little bit more detail about VUSs. So there's a couple of things. I always encourage my patients to check back every few years with either the genetic counselor or just the genetic testing lab to see if there's been any updates, because some labs, a lot of labs that we use will send amended reports if they've updated the classification of something. So we will get that information, but if they've not really looked into it or seen other patients at that lab, they may not issue an amended report. But the genetic counselor or even the genetic counselors at labs can help re-look into something to see if maybe there's been new cases that they've seen that's helped move that one way or the other. So definitely you can check back every few years, and labs will reissue updated reports too. And then there's research too. So if there's people that are looking into that, usually your genetic counselor can hook you up with somebody who may be an expert in that particular gene that was identified, so that maybe we can move it along someday to get more functional information about how that genetic change actually impacts the gene's function. It's a good question. I know they're this lingering thing out there for a lot of people. Usually they have a lot of the labs now have genetic counselors that will talk to people about things. So yeah, if you've not had a genetic counselor that you ordered the testing, so a lot of them you can call the labs and see if they have GCs that will talk about it. Okay, pause.
Question.
Oh yeah.
Sorry. So I want to ask about the genetic testings that are performed with different labs. How they match each other, or
they're pretty equal in the genes that they include for the most common inherited arrhythmias. And their technologies now, depending on who ordered the test and what they ordered, are pretty similar as well. So there are different ways that the lab can look at genes. They can look at them basically like spell check, right? That's the most common way, is there's like a spelling error in the gene. And so it causes that gene not to function properly. But sometimes there can also be missing or extra pieces of a gene. It's kind of like, probably if you've seen a genetic counselor, they might use this analogy. It's like if you're spell checking a book you wrote, you're not going to miss a missing page or a missing paragraph because you're just not looking for that. And conversely, if you're looking for a missing page or a missing paragraph, you're not going to find a spelling error. So usually we want to make sure both of those things are being done when we're looking at a gene. So it depends on when the testing was done and what genes were identified at that time, what we knew about. New things get added, and then making sure both of those methods were included. But now when I think across all the most commonly used genetic labs, most of the genes that they have are similar for like especially long QT, CPVT, and Brugada. Yep. And if you've had genetic testing, I encourage to get a copy of your report. So if you change or move, it is helpful if, especially if it was negative. I mean, even if it was positive and you have a family member who would like testing, it's helpful to know like, oh, well, we identified this new gene associated with XYZ and that wasn't included in your panel. Let's do that now. So it can be helpful too. So usually genetic counselors will send them, but even if you had it through your cardiologist's office, I recommend requesting a copy of that to store in your records. It can be helpful. Okay, back to a positive case example. I just wanted to give you to show you how genetic testing can kind of impact the family. This case in particular is CPVT. So the proband here, the first person that came to our attention, is a male who was a teenager who had a syncopal event while he was running. And then he was brought in and he had a normal resting EKG, a normal echo, but his exercise test was very suspicious for CPVT. So before he had genetic testing, what we would have counseled them on is it's mostly dominant, which means there's a 50% chance to your first degree family members, parents, children. He doesn't have children, he's only 16, but for his parents to also be affected. And we would recommend that they come in and get screening and evaluated like they're at risk. So that was what we did prior to genetic testing, because CPVT, there are two causes, or like two ways it can be passed down in a family. One's the dominant form, which is 50% to your family members, and there's also a recessive form, which means usually both parents carry a genetic change, but they themselves aren't affected, but their child can inherit both of those and be affected. So we call that recessive. So if somebody's a carrier, they themselves typically don't have that condition, but if their child has two non-working genes, they are affected. So after we did testing for this individual, he actually has a recessive form, which is rare. Only like 3 to 5% of people with CPVT have this recessive form. Vast majority have a dominant form. So that allowed us, one, to confirm that he had CPVT, and the cardiologist could then take that and implement that into his medical management appropriately. It also helped us give screening and family recommendations. So one, his parents